Hi. Hi, hello. Good morning to all. And on behalf of Neocon, I welcome you all for this advanced ventilation workshop. Excuse me. Excuse me. Can I get the slides also? Well, we got about 8 topics for the day, but the funda for the day is to keep it more interactive and to have more and more hands-on. Okay. So as excuse me, all know the more advanced we get, actually it is more simpler, and the basics are what is stronger when it gets more advanced. Okay. So the fundas for the day today, we would have a fixed concept which we would be reiterating as we go along the entire day. So it's not that we're going to have a lot of hi-fi equipment, we would be having, but at the same time, a little fundamental things is what would be stressed throughout the topic today. Okay. So the first one would be moderated by Dr. Karthik Nagesh, who is the HOD and HOD of Department of Neonatology at Manipal. I think we all know about Dr. Karthik Nagesh. He is joined us virtually. So before we get into the topic, I would like sir to give a few words. Excuse me. Yeah. So the first topic for today would be about the modes of ventilation and about the nomology of a ventilator. So all of us, I think, definitely would have ventilated newborn, and newborn the outcomes are definitely better, so that it always gives a sense of satisfaction. Yeah. So there are a few things which are special for a newborn. Okay. One of the first thing I would say is about the surfactant deficiency which we encounter in a premature baby. So you find that unless you open the lungs well and you are careful about it, it may collapse anytime. Now this is more common in newborn and more common in preterm babies. Next is the concept of pulmonary hypertension. Okay. So a little bit tricky, where a little on the wrong direction, again you are on the wrong track. Okay. You are always on the right track, but then a slight mishap, you again come back to square one. So that's one thing which is unique. And last one, well, what does that picture here depict? I think all of us picture. Well, you know, this is a child with a cerebral diplegia. Okay. Now this is a result of, I would say, one of the most common factors in this era is about cerebral hypoperfusion because of carbon dioxide, which is of hyperventilation. The carbon dioxide level is very, very important. Neuroprotection are moving from an era of saving the babies to now we are moved to an era where save babies with intact developmental potential also. So looking at the carbon dioxide level when you're going to is going to be paramount, and any low levels of carbon dioxide should be looked at as a medical emergency. Okay. So if you're going to ventilate a baby and you find a carbon dioxide less than 35, you are going to act immediately and ensure that you are on the right track. At the same time, extremes of carbon dioxide also is going to cause trouble. So this the biggest risk factor for this is hypocarbia, because hypocarbia causes cerebral hypoperfusion. Okay. Yeah, next slide please. Okay. I would be coming back into this slide again and again. Well, this is, I don't need to be seen. This is enough, I think so. Well, how does a ventilator work? Well, ventilator to start with is a very simple thing. Okay. It's just like a T-piece resuscitator. Okay. We all know about a T-piece resuscitator. One end, gas comes in. Okay. Then at the end of the T, you got the baby sitting there. The other end of the T, there would be a valve. Okay. Now, depending on whether the valve is open or closed, it controls the entry of gas into the baby. It's very simple. So gas enters, and then if you close it, air enters. That's going to be an inspiration. Now, how long that valve is going to remain closed will control the inspiration. Once the valve opens, the air is going to flow out. That's going to be an expiration. Now, how long is that valve going to remain? Yes, sir. Mariella? Oh, smoke. Yeah, correct. Sorry. Yeah, that's better. I don't know. Yeah, that's too small. Yeah, obviously. I think if not, I'll be closer so that.
ಸರ್ ಸ್ಪೀಕರ್ ಆಫ್ ಮಾಡ್ಬಿಡಿ ನೋಡಿ ಕ್ಯಾಮ್ರಾ
ಇದೇನು ಸೌಂಡ್ ಕಮ್ಮಿ ಮಾಡೋದು
ಇಲ್ಲ
ಸ್ಪೀಕರ್ ಆಫ್
ಸ್ಪೀಕರ್ ಆಫ್ ಓಕೆ ನೀವು ಹಾಕೊಂಡ್ರೆ ಸ್ಪೀಕರ್ ಆಫ್ ಕ್ಯಾಮ್ರಾ
ಕರೆಕ್ಟ್ ಅಲ್ಲ ಇದರಲ್ಲಿ ಕ್ಯಾಚ್ ಆಗಿ ಇದರಲ್ಲಿ ಬರುತ್ತೆ
But actually, over virtual, we will hear it mute only. சரி சரி இல்லை சவுண்ட் வந்து yeah okay so it's quite simple. Ventilator is quite simple. So the expiratory valve controls how long is going to be expiration, and depending on how much it's open or closed also you can control the gas flow. So that's a simplified part of a ventilation. Okay, next one. Yes, excuse me. Okay, so I would rush through this. Okay, so basically what we have to do is obviously give oxygen, remove the carbon dioxide. Along with that, we also have to ensure that we prevent lung injury. That's very important, because when we started, we all were just targeting the oxygen and carbon dioxide. Then slowly we realized, oh, just ensuring that numbers are fine doesn't matter, because over long term the lung does get damaged. So then we started fine tuning it that we don't damage the lung. Third is also ensuring a normal lung development and brain development. So these three forms the crux of an entire ventilation. Excuse me, next one please. Yeah, okay, so to simplify, I think people can come close so that I think it would sound that there's a lot of noise in the definitely. Online pocha, online connection, nothing there. Okay. Anna, அப்படியே அவங்களுக்கு சவுண்ட் கம்மி பண்ணி சொல்லுங்க. Okay. So coming on to alveolar gas exchange, ultimately what we know alveolar gas exchange is actually oxygenation is separate, carbon dioxide elimination is separate. What we call is medical parlance is carbon dioxide elimination. Okay. So oxygenation is ensuring the oxygen reaches the baby, whereas ventilation is more about carbon dioxide elimination. Now, do we try to separate it? When we are talking about conventional ventilation, separating it is quite difficult. Yeah, but over the day we would be talking about a high frequency ventilation, where in high frequency you find can oxygenation separately, carbon dioxide separately. In a high frequency ventilator, you want to eliminate carbon dioxide, you twist a knob that ensures only your carbon dioxide gets out. In high frequency again you got you want to ensure increase, there you twist a knob. Again I'm quite louder. Abhishek, sorry. But I'm not using mic at all. I'm not using mic at all. No mic at all. I'm just talking. But same, I can also hear them. Yeah. Yeah, next slide, please. Next slide, ma. So now coming on to oxygenation. Okay. Now the entire knobology depends on the oxygenation and the ventilation. So which knob you are going to twist when we are handling hypoxia? Which knob you are going to twist when you are handling hypercarbia or hypocarbia? So first is about the oxygenation. The first is obviously, as we all know, one of the no-brainers is going to be the FiO2. I'm not talking about that. Next comes to the mean airway pressure. Okay, next slide. Yeah, I think all of us, sorry. I mean, sorry for the technical hazards. I know it's quite irritating too. Yeah. So coming to this slide here. Okay, this is a pressure time loop. Okay, sorry. Okay, so pressure is on the y-axis, time is on the x-axis. Okay, let's keep it interactive. Okay, what's 1 here? What is this 1? So this is the pressure here. So this is the maximum pressure. Okay, that's the peak inspiratory pressure. That would be what we call as PIP. Okay, so what would this 2 be? 2 would be the PEEP. That's great. Okay, so this 3 here would be the inspiratory time, and 4 here is the expiratory time. Great. I mean, more interactive means we remain awake, and also at least our mind is into this. And what is 5 here? This is the inspiratory time, that's expiratory time. This is the peak inspiratory pressure, peak expiratory pressure. Yeah, click that, ma. Just keep continue to click. 1, 2, keeps coming down. Okay, now 5 here is actually dependent on the flow. Okay, now if I want to achieve this peak inspiratory pressure very quickly, okay, then you can increase the flow. But for starters, don't touch the flow at all. Just leave it at 8 to 10 to start with. Don't touch the flow, because what happens is you tend to achieve an oxygenation with an earlier peak inspiratory pressure, but that's going to be more traumatic to the lungs. Okay, so the slope, the faster the slope reaches the peak pressure, that's dependent on the flow, but you're not going to touch. So now this area, the yellow color here indicates the area under the curve, and that's called the mean airway pressure. In fact, the more you get to know ventilation, you just don't look at the PIP, PEEP and those numbers. You actually have to look at this number of mean airway pressure, which your ventilator would calculate, and it would give it on its screen. Okay, because everything, the oxygenation, the mean airway pressure is the end product. I mean, would ultimately lead down to how much the lungs are going to be kept open. So imagine you got a hot coffee. Okay, you want it to get cold, you want the heat to get dissipated. What do? You take it and put it in a saucer. So the saucer has more space, so it gets cold faster because the dissipation is better. Something similar, you again keep your lungs open better, so your gas exchange is going to be better. Okay, so the ultimate thing which ensures your oxygenation is going to be mean airway pressure, which is actually the area under this curve, that is the yellow one. Now, if I want to improve oxygenation, how do I improve this oxygenate this area? Okay, so there are many ways to do it. Okay, one is from here I increase the eye time, that will ensure that my yellow color becomes more. Next, sometimes I can increase the PEEP here. Now, out of all the parameters, the first thing you would have to do is, if you increase the PEEP, you can find that the blue color is more, because you're going, usually the expiry time you keep it more. So the first thing is the PEEP you increase a little bit, that ensures your area under the curve is more, which in turn is going to lead on to better oxygenation. Okay, that's one. Next, 2. What is 2? What am I doing in 2? Increasing the peak inspiratory pressure. Okay, now here you find that the area which I have increased is not great, though I do achieve a little bit. Okay, so maybe that's the second one. Okay, third, what I've done, I've increased the eye time. This is the eye time, because the eye time was here, now I've reached it till here. So I've got some more area which is more. Okay, and last is, like I told, if I improve the flow here, this slope becomes faster. So here I would get some more, but that's going to be counterproductive in terms of the lungs getting traumatized. Okay, so the crux is, if you can't achieve oxygenation, the first thing is try to open up the airways. One of the best ways is increasing the PEEP, but you're going to do that also. You just don't keep on going up on that. So you play around. I've reached the max. Then, okay. So these are the 4 ways in which you can increase the area under the curve, which in turn leads on to better oxygenation. So increase the PEEP, increase the PIP, eye time you can increase, flow increase. Okay, yeah, next slide please. Yeah, this is something similar. Yeah, next slide. Okay, so same thing, determination of oxidation is again the FiO2, then comes mean airway pressure, which in turn you play around with the PIP, PEEP, eye time, frequency and gas flow. Yeah. Excuse me, if I get a slight change, I would be happy. If I get a slight change, I would be a little happy. Yeah. Next, coming on to ventilation. Like I told, ventilation is about carbon dioxide elimination. Okay. Now, this carbon dioxide elimination ultimately depends on the minute ventilation. Minute ventilation is a product of the tidal volume and the rate. Now, rate is quite simple. Okay, you can increase the rate, reduce the rate. Okay. Now, how do you play on the tidal volume? Okay. Now, this tidal volume is again a component of the inspiratory pressure, eye time and the compliance. Okay. Now, what is compliance? Yeah, next slide, please. So, one of the biggest determining factor for your tidal volume, that is how much of air I can drive inside, that would depend on the compliance. Okay. Now, what basically is, go to the next one, ma. Next one, please. Okay. So, compliance is, in simple terms, is how much of volume I am achieving with a little bit of pressure I am going to give. So, change in volume for a unit change in pressure. I give this much of pressure, little pressure I give, I achieve more volume. That means that my lung compliance is good. I need lot of pressure to drive in, but still I get only little volume into the baby's lungs. That means the lungs are very stiff. That means I need more pressures also. Yeah, next one, ma. So again, well, for for a academic point of view, there are two types of compliance. Okay, one is called as the static compliance, another is called as dynamic compliance. Yeah, next one. Okay, what is static compliance? Well, static compliance in simple terms is you take out the lung, okay, and then you push a little air, see how much it's expanding. Oh, I can know the volume there. I have given so much of pressure. Okay, so the lungs alone you take out and calculate the volume and the pressure, you divide it. That's called a static compliance. But in reality, you can't do anything with a static compliance, because static compliance is only the elastic properties of the lung. It's more for a academic and a research purpose. Okay, what's dynamic compliance? Yeah, next one. Yeah, I maybe leave it here. Okay, now dynamic compliance is what is in real time. Okay, now here we got the lungs, you got the pleura, you got the muscles, chest wall. So everything together would add a compliance. Okay, so that's called as the dynamic compliance. So if you see here, now the chest wall, especially a newborn's chest wall, is quite flail and quite soft. So you find that with little change in pressure, you can see that this curve is quite steep. So it's very soft. Next comes your lung. Third is the total chest wall together. Both together, you find that now it is a little lesser. Okay, that's quite simple. Okay, dynamic compliance is the entire lungs with the pleura and the chest wall, whereas the static is just the elastic property of the lung. Okay, next one. Yeah. Okay, keep going, keep going. Okay, so basically, whenever, okay, we would have a separate section on pulmonary graphics too. Well, basically, whenever you're going to ventilate along, you always have to see this PV loop or pressure volume loop. The slope of this curve will indicate how good is your lung is compliant. If this entire curve is lying down, sleeping, it means that your lung is very, very, very stiff. Okay, that's an indication. You have to give surfactant, or what you're going to do, you have to check out. Okay, now this is standing. It means that your compliance is really, really good. Okay, yeah, next one. So, in fact, yeah, this is a baby who had RDS, then you had given surfactant, that's better. So, this is a baby with an RDS. Okay, what I want to say is, have a habit of looking at when you're starting to ventilate. Over time, you realize that, okay, this is how it's happening, and you find the response, because just numbers or just putting a tube inside the baby doesn't finish our job. Keeping an eye on the baby as well as the curves as we evolve, as the baby goes forward, you'll know, okay, you find that the curves better. Next day, you find that again the curve is again flattening. What is going wrong here? Do we need to give one more dose of surfactant, or is the baby's lungs getting flooded? Means what could be happening? Imagine you got a preterm, you gave surfactant, it is standing. Next day, you find it's again started sleeping. What all possibilities could be? One could be a PDA, or slowly you started having some infections where your lung is again going to become. So, this will give you a good idea of the dynamic changes which are happening. Yeah, next one. Yeah. So, here I would like to add up one point about the opening and as well as the over expansion. Okay. Now, if you see this curve, again the pressure volume curve. Okay. Now, to open the lungs, okay, there's a little bit of pressure. If you see the bottommost part of this curve, you find that with a little change, with a lot of change in pressure, there's not much of change in the volume. Okay, so whereas at the end also you see that the change in pressure is more, but again you can't achieve much of volume. Okay, whereas this is the ideal part, which is called a normal FRC, functional residual capacity. where a little change in pressure, you get good amount of volume driven into the lungs. Okay. Now, what does this signify? Well, this signifies that you give a little more PEEP so that you ensure your lung is already open here. Beyond that, whatever PEEP you give will ensure that your lungs are going to get open well. Otherwise, what happens if you give a less PEEP? What happens is you are actually the pressure, more pressure to drive the air inside, which is again going to be more counterproductive. Your lung is again going to collapse. Again, you're going to open it up. So that's going to be counterproductive. So always you have to work on the middle line. That is the normal or the ideal functional residual capacity. So you should know that again keeps changing for each baby and each pathology. So this is the, you start from here. Again, coming to the end point again, at the last half, you can see that the lungs are already quite expanded. Beyond that, you try to drive in air, still pressure you're driving in, you are not much of volume. You are have to do something else to ensure your oxygenation again. So, yeah, next one, ma. Okay, these are depicted in numbers also in most of the ventilators. Yeah, next one. Yeah, so come back, no? Yeah, come back. Okay, so now whenever you see the pressure volume loop, also you look into the right hand side. In most of your ventilators, you have a few numbers which pops out. One of the numbers which pops out is called as the C20 by C. Okay, now I mean that's a compliance. Okay, where now basically the pressure volume tells you the compliance. That is how much is the slope of this curve is indicative of your compliance. Okay, so now imagine the C is the compliance of the entire curve. C20 is the compliance of the distal 20% or the last 1/5 of the curve. Okay, hope I'm not going too fast. Hope everybody are with me. Okay, I know there are a lot of disturbances, but still we have ventilators, and again we'll be talking the same thing throughout the day. Okay, so coming back, so now this ratio is C20 is the compliance of the last one, whereas C is the entire compliance. Now, if we are over distending, what's going to happen? The last stretch is going to get more and more flattened. So your compliance is going to reduce, whereas bottom C is still more. Okay, so what's going to happen? Your ratio is going to be less than 1. Okay, so at the same time, if you find that still the lungs are expanding well with a little change in pressure, the last stretch is going to be like this. So what's a, yeah, so if C20 by C is more than 1, then at tidal recruitment may be occurring. That is, still there is recruitable lung, you can go up on the pressures. Whereas it is 1 means, it means maybe it's not going to recruit further. It's high time you stop moving up the pressures. Whereas C20 by C is less than 1. If you are seeing numbers of 0.8, now it means that you are over distending the alveoli. You may blow the lungs, so you're not going to achieve anything by pushing up the pressures. So these small clues will give you a lot of information about what's going to happen 2 hours later, 4 hours later. Okay, yeah, excuse me. Next, coming to the concept of time constant. Okay, now all these are little complicated jargons, but ultimately few take home here which will tell you what you're going to do. Okay, now time constant, the formula for that is resistant into compliance, and there's a lot of definition about that, but in simple terms I tell you about time constant. Now time constant is the time needed, okay, for the air or the gas to reach from the starting of the, that is the atmospheric pressure, to equalize the alveolar pressure. Now imagine what happens, gas flows from high pressure to low pressure. To start with, your lungs, the alveoli has a low pressure, so it starts flowing from outside to inside, and then the pressure equalizes. So the time needed to equalize the pressures from the from outside, okay, outside to the end alveoli, that's called time constant. Okay, now imagine, okay, you got a very hard lung, an iron lung, you imagine. Okay, now as gas starts flowing from outside and starts coming inside, it is very stiff. Okay, now how long does it take for the pressures inside to build up? Is it more or is it less? Imagine it's very hard here, air starts flowing slowly inside. Anybody? You've got a very hard lung, so even little air goes. Now if it's very soft, it keeps on expanding for a long time, so your pressure builds up slowly, whereas already it's very hard. even little air comes in, what happens? It gets filled up already, then your pressure starts building up. So what happens if it is stiff lung, your time constant is going to be less, and this time constant decides how much you're going to set your TI or the inspiratory time. Hope I'm not confusing. Okay, I mean, even I thought the same when I started, because okay, it's going to, you can build up a lot of air inside, but what happens even when it's very stiff means even with little air coming in, it is going to tell the pressures are going to rise up. Okay, it's like there's no more space to expand, pressure is going to build up. Quite soon your pressure will build up. If you're going to deal with a very hard lung, okay, like an RDS, sometimes you keep a little less of TI. Okay, so probably, and more premature babies, sometimes you keep more and less inspiratory time. Okay, but again, in newborn, there will be a lot of overlaps. Okay, we're not just talking about stiff lungs. Sometimes you have an airway problem in a meconium line or some other problem. So there are a lot of overlaps also. But the crux is, if the lungs are very stiff, you are going to give a little less I time. But at the same time, now imagine in a bronchopulmonary dysplasia. Now bronchopulmonary dysplasia, basically you get a, okay, you got a bronchospasm. Suddenly you got a BPD spell. What exactly is happening? It is going for a bronchospasm. Okay, so BPD has a problem of the airway also, whereas RDS is more of a problem of the alveoli, whereas here you have problems in the airways also. So your airways are going to go in for spasms. So your resistance is more. So here is the time constant more or less? You got a narrow airway here. You have to build up the pressure here. Now slowly air will come little and slowly fill up the alveoli. So it's going to take a longer time. So in BPD and all, if you're going to ventilate a baby long term, I mean at 1 month for a BPD spell or something, you keep a little higher I time. When it's a meconium aspiration syndrome, here it's a mix of both. Your alveoli is again going to be stiff because the meconium has damaged the lungs because of pneumonitis. Again, your airways are blocked by this one. So here you give somewhere a middle. Okay, so that's how you decide about the inspiratory time you're going to give and the rate also. Okay, next one, yeah. Stiff lung RDS, it will be low compliance. Okay, yeah, keep going, keep going. Yeah. So that's the crux of the entire mean airway pressure, entire thing, and elimination goes with the minute ventilation, frequency, and tidal volume. Going. Yes, please. Okay. Okay. I mean, I'll rush through, but we again have the same thing through the sessions also. Okay. So now, okay. Now coming to which is the mode we select again. Okay. Because many of us use different ventilators. There are many terminologies there. All the alphabets are put into something and tell that this is we got this mode, this mode, this mode. The crux of it is you should be comfortable with the mode you have in your ventilators, but you should know how it works, because all of them ultimately would have the basic fundamentals. Okay. In the modes, there are 3 parameters you will have to see. All modes work, I mean, have this 3 parameters. Okay. So like I told you, a ventilation basically is gas flow comes in, you got a expiratory valve. So when the valve is closed, air flows, that's inspiration. When the valve opens, that's expiration. Okay. So how it controls? So trigger is the one which starts the breath. Okay. So when the trigger happens, immediately air flows into the baby. Come is the limit. Okay. Beyond this, you don't give. It could be pressure or volume. You have some number. The ventilator has some numbers in mind. Okay, this much of volume, then I'm not going to. I'm going to move away. Okay. Then comes the cycling. Cycling is when it moves from inspiration to expiration. Okay. So there are 3 parameters here. One is the trigger, limit, and cycling. Okay. Now each of them can be controlled by different parameters. Sometimes the doctors can control. Sometimes the baby controls. Sometimes there are other parameters also. Okay. So trigger, limit, and cycling. Yeah. Next one. Okay. Now coming to the trigger. Okay. Now we are moving more and more where a synchronized ventilation, where you let the baby control its ventilation. Okay. So before and all, we were controlling everything. Then we found that asynchrony is one of the biggest causes for a lung damage. Okay. Here trigger can be could be just time control. That is, you say you got a 60 seconds means every 1 second you start a breath. That's called time. So what the machine does, 1 minute, 1 second over, 1 breath, 2 seconds over, 1 breath, irrespective of what the baby is breathing. That's called as the CMV, patient interaction. We don't use this at all. Okay, there are some ventilators which still have a CMV mode of ventilation. Next comes the pressure. Now here, what happens is there's a anemometer inside which will tell, okay, the baby takes a breath. Immediately what the machine diagnoses, okay, picks up, oh, this is a breath here, let's start the inspiration. Next, there is something called flow. Okay, now flow, how basically it works is there would be a heated coil inside. Imagine there's a high heated coil where you got a temperature sensor at both ends. And imagine there's just a whiff of air. What happens? Temperature immediately drops at the distal end. Immediately the machine senses, oh, there is a breath inside. Okay. Now, many say that this flow triggers are one of the most sensitive, because even the smallest flow of air, immediately there is change in temperature, immediately it's been picked up. Okay. So that's a flow trigger. Then you got the normal movement and chest impedance, where you place these are all still in the development stage, I would say, where you place a small, like a temperature sensor, you place it on the abdomen, and that senses. Finally, it's the NAVA, which again, over future, we may use it. Sir is specialist in that. Okay, coming back. So this basically what it does is, the diaphragm is there. You place a sensor near the diaphragm. So what's going to be, it's going to pick up the electrical activity of the diaphragm itself. So in fact, that would be the earliest. That would be the most sensitive, in fact. Okay, you can imagine the baby is immediately, you know the baby is going to breathe, immediately you deliver. Okay, so that's how a NAVA works. Okay, neurally adjusted ventilator asset. Yeah, next ma. So limit is very simple. Okay, you either you limit your pressures or you limit your volume. Okay, now the first curve here you see that. Okay, now pressure is already reached, and then that pressure doesn't cross that. Second one is the volume, where you achieve a volume, but here the pressure is, it rises slowly. I think during the graphics they'll teach you about this. Next one. Okay, third one is, okay, what is the trigger or what causes the breath to end? When do you move from inspiration to expiration? Again, it could be, many times it's time. Okay, 0.3 seconds over, move to expiration. Okay, but what would be more friendly is obviously telling the baby, asking the baby, when do you want to go into expiration? Okay, that's called a flow cycling. And then volume in adults we have. So basically most of the cycling is based on time, but there are a few modes which again lets the baby control the inspiration change. Okay, yeah, next one please. Yeah, excuse me. Yeah, Rashidma. Yeah, okay, so I would rush through this again, we'll come back. So yeah, please excuse me. So basically these four modes is the say are the basic ones, and the same thing you would different terminologies. So IMV, SIMV, synchronized intermittent mandatory, SIPPV. In some machines it is time cycle pressure limited, that is TCPL. In some machines it is AC, that is assist control, and then you got the pressure support ventilation. Okay, so these are the four, majority of the ventilations are in these four modes. They play around this. Along with this, they add volume guarantee and those things. Okay, yeah. Okay, so in IMV mostly we don't use it now, but it's very simple. Intermittent mandatory ventilation. Okay, there is 1 minute and I want 60 breaths there. What the machine does, it divides into 1 second space. Every 1 minute it gives a breath. Okay, irrespective of what the baby is going to do. So what happens, there is no chance that it's going to, so basically there will be a lot of dysynchrony. So you're not going to use. Next one please. Previous one. Yeah, so in SIMV, that is synchronized intermittent mandatory ventilation. Okay, here how it works is, now the machine wait for a few microseconds to wait to see if the baby is going to breathe. Okay, same. Okay, I want in a minute 60 breaths. So again it divides into 1 minute cycle. But at the beginning of each, that's called as the window period, where the machine waits for the baby. Okay, is my baby going to start breathing? Once the baby starts, it immediately synchronizes with that. Now, out of the time, that window period, it won't synchronize, but at least it waits for the baby to tell, okay, it's going to start breathing. If it starts breathing, immediately it catches on to that, and then expiration will be based upon the time only. Once the time is over, okay, 0.3 seconds over, it moves to expiration. So you find here, okay, now if you see here, this, okay, this is a baby breath, baby initiated breath. That's called a assisted breath. That's called a control breath. Now you see in both the way, you can see enough pressures and enough volume is reached here. Now how do I say this is a baby's breath? If you see this kind of a graph, okay, how do you say this is a baby breath that has no baby effort? It's just the machine which is driving in. Very good. So whenever you see this negative deflection, it means that the baby has initiated breath and then machine has, so that's called a assisted breath, that's called a controlled breath. Okay, but what happens is, now as you see here, the in between breaths here, so these are all the machine is assisting, whereas these in between breaths are not supported. So what happens here, the pressure delivered as well as the volume which we are achieving is not optimal. Whereas you, okay, if I'm telling the baby, okay, I need 40 breaths in SIMV, it gives 40 good breath. But if the baby breathes 60, the remaining 20 will be the baby's own efforts, which may not be that great and not that optimal. Okay, so that's about SIMV. Next one. Okay, next coming on to assist control. This is otherwise called as SIPP in few. In few, it's called as time cycle pressure limited. Okay, now what happens? Now the baby, similarly, you're going to wait, the machine is going to wait for the baby to take a breath and then assist it. Now in between breaths also, the machine still supports. Okay, now what happens? Baby starts a breath, immediately machine goes through. But in between, again, the baby takes one more breath. Immediately, again, it moves into inspiration. So what happens if you're set at 40 and your baby is breathing at 60? All 60 would be supported. Okay, go to the next one. There's a graph there. Yeah. So you find that all the breath, irrespective. Okay, sorry for the quality. I think it's okay. So all the breaths would be supported. Either assisted breath. Assisted means baby machine is going to support or assist. Whereas control is entirely the machine. Okay, that's the assist control. Now the flip side to that is sometimes what happens, you're going to have an inspiratory time. Okay. Yeah, it's tough. Okay, so you have an inspiratory time. So what happens is, inspiratory time you're going to say, the remaining is going to be expiratory time. So if the rates are going to be higher, the machine ensures that the inspiratory time is same. But what happens, the baby starts breathing more, your expiratory time is going to come lesser and lesser and lesser. So what happens, you have told the machine to breathe at 50, but your baby is breathing too fast at 90. So what happens, it will try to support that 90 breath. But the flip side to that is, inspiration will be the same time, but your expiration is going to get more and more and more smaller. What will happen if your expiration is going to be more and more smaller? Yeah, one is carbon dioxide, another is air trapping is going to happen. So you gradually find that your lung is going to get bigger and bigger and bigger. So the flips, so I mean, I ask my residents, okay, ma, what is the ventilation you worked with modes? Some people say SIMV, some people say SIPPV. Now, why do some people use this one, some people use that? Well, in SIPPV, as we told, all the breaths are supported. Now, imagine you got a high volume unit where you ventilate 10 babies and you got one nurse handling 5 babies. A lot of water condensation in the circuit there. Now, each of the movement of the water droplets would be detected as a breath by the machine. So, what happens? It starts hitting haywire. So, you will have high rates hitting there. But what's going to happen? Actually, it's not the baby's breath, but it's going to, so your expiration is going to get lesser and lesser. Now you're going to have more and more air trapping, so it's going to be counterproductive. So that's why the senior doctor there felt that, okay, SIMV is better here. For starters, I mean, each of the modes also depends on what your unit is comfortable, what your nurses are comfortable, what your entire team is comfortable. So at the end of the session, okay, we have learned a lot about high frequency HFOV. I'm going to do HFOV for all my babies. No, you need your entire team comfortable. Similarly, your modes also. Your unit may be comfortable with one. You tailor yourself to that. Okay, coming back. So that's about the SIPPV means all breaths are supported. SIMV means only a set number is supported. Yeah, keep going, make it fast. You're already running short of time. Yeah. I think last few says, please go, ma. Please go. Okay, the next one is pressure support ventilation. Anybody have used this PSV? Good, at least nobody has used it because even we don't use it as a primary mode. No, in PSV, it's in simple terms is, now in SIMV, what I said, 40 will be supported, remaining 20 are not supported. So that remaining 20, what happens, the baby huffs and puffs to pull out air inside. There what you do is, you just give the boost a little bit to the baby. Okay, I won't give you the entire one, I just help you a little bit more. Okay, you can make only 8 pressures. I'll help you up to 15, though I need 20 ideally. I'll help you out a little bit. Now, what is the idea of this is sometimes the narrow tube. So imagine the baby is trying to breathe through that narrow tube. There's a lot of pressure to pull out the air inside. So what this does is it pressure supports a little bit, not ideally, but little more than what. So this helps the baby to breathe a little more easy, lessens the work of breathing for the baby. So it's majority used as a weaning mode. So many times it will be SIMV plus PSV. Okay, so that's how it will be. Many times when you're going to wean, so SIMV plus PSV, they gradually increase it. Okay, that's all. And one more thing here is obviously this the expression here is also controlled by the baby. Okay, that's called a flow. Yeah, keep going, please. Excuse me. Next slide, please. Yeah, this is PSV. Okay, keep going, keep going. 1 second. Yeah, here now you hear now this is moving from inspiration to expression. The bottom one is expression. Okay, now in normal SIMV, SIPPV, inspiration to expression, that's called a cycling, right? Cycling is basically time. Okay, so you 0.3 seconds over, it moves. Now, what's the time now? Excuse me. 10:20. Yeah. So, okay, last few slides. So, in usual ventilation, so 0.3 seconds over, you move to expiration. So, that's no control by the baby. Whereas in PSV, what happens is the machine recognizes the flow, change in direction. It's always in the positive, I mean, inspiratory. Suddenly, baby takes a breath. There is an expiration, okay? I mean, expiration again. So, change in direction would be detected and immediately it changes over. That's called as a flow cycling actually. So, PSV is more for weaning because now you let the baby itself control both inspiration and expiration. Okay, keep going. Yeah. Okay, last with a few questions here. Yeah. Okay, yeah, keep going. Okay, now keep it there. So, all called as scalars, where basically you in the x-axis you got the time, here you got the flow, pressure and volume. Okay. Now, first is the pressure there. Second is the flow, how much you achieve. Third is the volume here. Okay. Now, what is the mode which is depicted here? Anybody? Okay, what is the mode? Yeah, keep going. So, okay, next. Yeah, which are the synchronized breaths here? Now you got numbers here also 1, 2, 3, 4. These are the breath numbers. So, which are all the synchronized breaths here? Now, come back, please. Sorry. Yeah. So, synchronized breaths are 1, 4 and 7. Okay. You find that your pressure, you're achieving the right volume, okay, and at the right time. Okay, next one, ma. Wait, stop here. Okay, so what is the mode you find here? Sorry. What is the mode here? Plus PSV. It's not SIPPV. So you find that now the intermittent breaths which were actually lesser volume, here you have a inspiratory pressure boost or pressure support. So, the in-between breaths also are supported, not as good as the control breaths, but still you have a little more. Okay, that's called SIMV plus PSV. Okay, what are the PSV breaths here? Well, that's same. Okay, 2, 3 and 5. Yeah, next one, last one. Okay, what is this? Okay, there's only one left behind. Yeah, assist control. Okay, so okay, which are the assisted breath here? Stop it there. Which is the assisted breath and which are the control? Which is the control breath here? No, one of them is control. Last one is control. Okay. Negative. Yeah, I think I had a few more. I think keep going, ma. Just rush through. Yeah, these are the final terminologies we are going to play around. These are knobologies. Okay. Last one. Yeah, keep going. Okay, there are two. Okay. Now, finally, with these terminal knobs and everything, modes you got, what are we actually working on? Finally, we need the baby safe home. It's like finally a sport only. Finally, you need to win the game, but you're not looking at the far. As Dhoni says, you look at the process. So each one you have small targets on the way. You try to achieve those targets, and ultimately your end goal would be reached. Here, ultimately, you're achieving what you're going to look out is the ABG. Now, working on using a ventilator without a blood gas or a ABG is like using a computer keyboard without a monitor there. You just keep on typing something, but what's actually happening, you won't know. So ultimately, you need to know what's happening at the cellular level of the baby. Okay. Now, out of these 5 meters, all 5 are important, but I would say, I mean, personally, 2 numbers will always worry me. One is the pH and base deficit. Why I'm very particular about this is when this goes haywire, it means the baby is going to anaerobic respiration. It's just a few hours away from death or even few minutes from death. So whenever these numbers are getting little haywire, it means that you are in emergency. Whereas the other numbers you play around, PO2, watch for hyperoxia, PCO2, watch for permissive hypercapnia, and base deficit and pH is what you also always have to keep an eye on. These numbers, again, targets keep changing. Your unit should, okay, this is the pathology in the baby, this is the numbers we slowly want to achieve. Okay, sometimes you have very sick babies, sometimes you achieve, I mean, you accept a little high carbon dioxide, little low oxygen, provided your pH and base deficit fine. So you are not going to stick to one number, it depends on the baby, and ultimately you are slowly going to achieve the target. Okay, yeah, I think I would stop here, keep going. I think we'll deal again with these things, individual things again. Okay, I think I would call it now, so that we are running short of time, so evening also we can go back early. Keep going, that's it, I think that would be it. Keep going. Yeah, so, okay, these are, just take home, yeah, just rush it, ma. That's what you have, so oxygenation separate, ventilation separate, MAP and the FiO2, ventilation is tidal volume and the respiratory rate, okay. Time constant, like I told you, depends compliance into resistance. A stiff lung means a time constant little lesser, keep lesser TI, yes, please go. Yeah, keep going, keep going. Yeah, I told about trigger, limit, cycle. SIMV, all the breaths are not supported. 35 and baby is going to be 10, which is not supported. Okay. Yeah, PSV is flow, triggered, and pressure limited. Okay. I think again the entire thing will be repeated again as we go through the stations also. Any doubts in between also we can have through. Okay. So yes, the next session would be. Yeah, I think I'll run it through again. Yeah, in fact, individual conditions, right? I'll come through that again, okay? Because, I mean, yeah, you just come back now, last few, no? Yeah, the previous one. Yeah, RDS here. Well, like I told you, just keep it simple here. All taken. It was one of, I would say, like a Bible of ventilation, but then, so numbers here. No, my next one. Yeah, I think this would be better. So in RDS, like I told you, you are going to have a stiff lung. Okay, so your I time is going to be less, and what's going to happen if the baby is going to breathe more? You're going to have a lot of air trapping. So you're going to have rapid rates. Okay, one is rapid rates. Rapid means you're talking about, don't go to 60s, but at least 50, 60. You're going to have a lesser I time, 0.3 or 0.335 like that. In fact, more smaller baby, lesser I time. You're going to have a moderate PEEP, at least 5 to 6 you can give. Low peak in spirit. Don't keep on going on high pressures. That's going to be more traumatic to the lung. And always, sir will talk to you. Okay, and that's the targets there. Again, in premature babies, sometimes you accept targets of 7.2 also. Okay, so you don't go to, I mean, try to achieve high targets. Okay, so 7.2 PaO2 of 70. The crux is hypercarbia. You can accept carbon dioxide 55, 60 also, because you don't, in pediatric, if you see, we accept 35, 40 is what we are targeting. If you get that number, you're going to bang the lung too badly, which is going to be traumatic. So rapid rates, moderate. Yeah, next one, please. Whereas in PPHN, you're going to still have higher rates. Okay, and here you're going to give a little bit more peak pressures because you want to achieve that oxygenation. Okay, and PEEP is going to be low because here there may be a little bit of air trapping. Here the I time is little moderately high. Probably you keep 0.35 like that. Now, again, these numbers are not set. There's nothing to mug these numbers and start with that. Okay, it depends on the pathology because there will be a lot of overlap in it. Okay, yeah, next one. And BPD, like I told you, it's slower rate because here slowly the air is going to go and reach the terminal alveoli. So you're going to give slower rates, a little higher I time. So here and all, if you see 0.4, 0.5, you keep it. Slower rate and low PIP also and tidal volume. Okay, and carbon dioxide, you accept a little more because the baby is going to be bigger. Okay. A little crux of the initial settings you're going to, it's all initial settings. Again, there will be a lot of overlaps. I think that would be it, ma. We'll again deal the same thing to the stations also. Okay, so feel free to ask us also. So next is yours, no sir? Correct. Okay, so next is I would like to welcome Dr. Rahul Yadav sir. He is my teacher and he's a person who will keep the sessions very lively, and he's one of the best teachers in India. I would vouch for that. I think many people would know that, okay? And it's more practical. That's what, because it's not about theory and talking a lot about evidence. The best part about sir is it is all hands-on and he tells you how to do it. Okay? Thank you, sir. Welcome, sir.
Good morning, friends. Am I audible now? Yeah. Actually, uh, I like the delegate who asked. You the only asked. No, I want to take photograph of the last few slides because this is thing we come for workshop. We come for workshop to know what to do. What to do. That's all. So this to what to do should be our main focus in this workshop part also. Next one. So what got these three questions? We start with these three questions because can you go back? Can you go back? Our question was pressure limited versus volume limited. So I would like to ask all the audience, how many of you think that pressure limited is better than volume limited? How many of you? One, two. How many of you feel that volume is better than pressure? One, two. So there are a lot of people who are undecided, who don't know volume versus better pressure. What is better? Many people don't know, and they are our main audience. Now, is it wise to take a stand, or is it wisdom to have a middle way? Well, that thing we'll discuss. Why I want to discuss this one is, recently I happened to be in my batch get together, and this question came to me way back. So I asked my friends, two of my friends who came from abroad, USA, for get together. One was fan of pressure, one was fan of volume. Both are adults, adult ventilators. So they're fighting. I was listening to them about all the fights going on and all. At the end, I asked them, suppose third wave of COVID comes here only, India, and you are about to be ventilated. How I should ventilate? The person who was fan of volume, he said, please don't ventilate me by volume. I said, why? All the patients of COVID who have died, they were on volume only. 50 lakh people have died on volume ventilation. Don't forget that. All of them. COVID ventilation, volume ventilation has miserably failed. This is also true. Then I asked another friend, suppose you get mild COVID, you get up, you get giddiness, you fall, you get cerebral edema. Now very tight control of CO2 required. Now what do you want? Shall we ventilate pressure? No. Please ventilate by volume. So I got the message that your stand is something which is based on actually your passion. You like something doesn't mean that it is perfect. Nothing is perfect. Pressure is not perfect, volume is not perfect. So we have to individualize the patient for volume and pressure, because I have done both. After doing both for many years, I gravitated to this side, but I should know that neither pressure nor volume is the ideal mode of ventilation. So speakers, they tell always volume in NICU conference. I have attended adult conferences, attended PICU conferences. In adult conferences, they say, look at the newborns. They are beautifully ventilated, fantastic outcome. They are using pressure and we are using volume. Go to PICU. They also look at newborns. So always grass is greener on other side of fence. So don't get carried away by any propaganda. Pressure and volume, both we'll discuss, but we'll try to find out individualization. You got both modes. You got both. Compare. And at given patient, whether to do this or do that, that we'll discuss. No theory, no graphics, directly carry your message. No discussion at all. So carry your message, and later on we'll explain. We'll start with carry your message. So carry your message comes back. Next one. So why these three questions are, after listening to their fight, there are a few actually very odd what we can say, questions are there. Shakespeare asked to be or not to be. Then we'll discuss whether CPAP versus HFNC. Then we'll discuss about happiness versus success. These are these questions we keep on discussing actually. It is not actually quite wise questions. Similarly, this question, volume versus pressure, is not a wise question. So let us call, because I was asking this question, I felt myself to be stupid after listening to their fight and ultimate issue. Next one. So they are ultimately stupid questions. Now the better question is how to select patient for volume or pressure. How to select given patient for this one. So this is a complementary modes, not competitive. Don't put competition between them. CPAP and HFNC are competitive, no. Complementary, yes. Similarly, pressure and volume are complementary to each other. If you got both options, then your job is done. So that we'll see one by one. How to select? Whether we are selecting a patient, given patient, for volume or pressure, first of all find out whether the baby is having distress more than tachypnea or tachypnea more than distress? Very important. People say baby is having distress and tachypnea. No, patient will have either tachypnea or distress. Intermittent distress with tachypnea or intermittent tachypnea, but at given moment, patient can't have. What is more? That is important. Distress means baby is having hard to breathe. Compliance has come down or resistance has increased. Tachypnea means he's trying to wash out CO2. Tachypnea means wash out CO2. Understand that pressure ventilation is predominantly related with O2 and volume related with CO2. O2 problem usually leads to a lot of distress and CO2 problem leads to a lot of tachypnea. It is just a rule of thumb. Distress or tachypnea. Second thing. Next one. So suppose just breathe. If you are having difficulty in breathing, means what? Your I time or E time is prolonged. You are having inspiratory difficulty or you are having expiratory difficulty. When time gets prolonged, the respiratory cycle gets prolonged. You can't have tachypnea and distress simultaneously. You can have alternating. But at given moment, you see all the babies, you get lot of tachypnea, intermittent grunting, or lot of grunting, intermittent tachypnea. That we see commonly. That itself is actually it gives way. What is the problem with the baby? Bronchiolitis baby, they are having tachypnea but no distress. RDS baby, they are having distress, very little tachypnea. So distress more gravitated towards pressure. Tachypnea more gravitated towards volume, because volume is about CO2, pressure is about O2. Grossly, it is not actually this one exactly. All these things we'll discuss afterwards. Next one. Next one. X-ray white or black and white. White X-ray means actually there is gasless lung. Gasless lung means either fluid or absence of air, and absence of air, a lot of inflammation. So this particular white lung requires certain pressure. Now the pressure should be consistent, at least in the initial phases. So whenever you get X-ray which is white out lung, then we prefer more about pressure. And black lungs or black and white lungs, like black lungs volume. Black and white is very typical. Some black, some white, some are collapsed, some are overexpanded. What happens with volume is it delivers certain amount of volume. Whether that volume goes equally to all the areas of lung is not taken care. So volume ventilation main problem is the poor becomes poorer, richer become richer. So atelected trauma is more common with volume, and this volume trauma is more common with pressure. So this in non-homogeneous lungs, they are actually benefit better by pressure, not volume. Now, this particular thing, majority of our colleagues may not accept it. Why? Because what I observed is volume ventilation is liked by those neonatologists who practice inborn neonatology. The baby comes quickly, surfactant received fast, so there is no whiteout lung. And those who practice outborn neonatology, where babies come late, whiteout lungs, we have to give surfactant very late, advanced stage, they don't respond much to volume, they require pressure. So white, pressure, black, volume, black and white, again pressure. So these are the gross. This one. Next one. Next one comes up is peritubal leak. Now what are the enemies of ventilation? Enemies of ventilation means when you use pressure ventilation, your enemy is attenuation. What is attenuation? If you give pressure of suppose 20 at here, that doesn't mean pressure of 20 going to alveolus. The pressure goes down suddenly in steps. This is attenuation. This is enemy of pressure ventilation. Volume ventilation, what is the enemy? Volume loss. Volume loss. Suppose certain amount of 5 ml per kg volume is being given, but there is peritubal leak. Volume loss. So volume ventilation requires perfectly sized ET. So actually I have worked with both. When you are using pressure, you are always obsessed about placement of ET. In volume ventilation, obsessed about size of ET. When pressure ventilation, tube up, tube down, tube kink, that creates a lot of problem in pressure. But that doesn't create problem in volume. But volume wise, the ET size should be pakka. There should not be peritubal leak. Volume ventilation, they doesn't tolerate much of peritubal leak. Volume ventilation does not work in PIE, pulmonary interstitial emphysema. It does not work well. Volume ventilation does not work with pneumothorax, because whatever volume is given is not going to always lost. So these three conditions, PIE, pneumothorax and peritubal leak, volume ventilation usually does not work well. Next one. Bronchospasm versus bronchomalacia. The CLD spells used to get few years back. Somehow the CLD spells have come down. It is being replaced by bronchomalacia. Sudden bronchospasm versus bronchomalacia. How to differentiate? Both of them lead to wheezing. But this bronchomalacia leads to polyphonic wheeze. Bronchospasm leads to monophonic. This one, I have to observe, same wheeze will be available very well. So this bronchospasm, what happens? If there is this spasm is there, it is a permanent. Now, if you ventilate by pressure here, that flow required for that buildup of pressure very high. High flow is delivered. So that high flow actually is not desirable. So for bronchospasm situation, volume is better. For bronchomalacia, pressure is better. Next one. Oxygenation stable or unstable. For oxygenation, what is required? Oxygenation, what is required is VQ matching. VQ matching. Ventilation different, oxygenation different. So for VQ matching, there should be adequate recruitment of alveolus. If there is not adequate recruitment of alveolus, then oxygenation fails. If your predominant problem is oxygenation, then volume ventilation is not a good choice. Then actually pressure ventilation is a good choice. Classical example of this problem is COVID. In COVID, oxygenation was a problem, and all the patients of COVID ventilated with volume, the results are open. Once COVID patient goes on ventilator, does not come out actually. A lot of deaths have happened. So oxygenation, pressure, ventilation, CO2, more this one is volume. Beautiful control of CO2 is achieved by volume, and better control of oxidation is achieved by pressure. Next one. Tight CO2 control required. As sir pointed out last this one, tight CO2 control is not required in older and more mature babies. But in younger and preterm babies, tight CO2 control required. If there is hypocapnia, hypercapnia, they go for IVH. So this fluctuating CO2 because of pressure is very bad for young extreme preterms whose lungs are already improved. Improved lungs. Lungs are not that bad, but brain is vulnerable. Better improving lungs with vulnerable brain, young extreme preterm baby, volume is perfect because volume ventilation is based on CO2. So by volume, we can actually keep the CO2 in actually prescribed range, which doesn't happen with pressure. You must have seen ET slightly up, tube kick, little bit here and there, CO2 goes up. Oxygenation is maintained, but CO2 goes up. So for good CO2 control, volume is better. Next one. Next one. Next one. So these are the just gross thing. It is not perfect actually. I'm trying to oversimplify it. It is not as easy. Actually, both these things can be achieved by both. But overall, next. Next. The same thing you are telling. Next slide. So this will try to make it actually objective. This is actually carry on message. This is the end of the talk actually. Distress more, prefer pressure limited. Tachypneas more, prefer volume limited. There is hypoventilation. Now hypoventilation means what? Typical situation is central hypoventilation. HIE with good lungs. Because that's why the adult intensive, they like volume because their lungs are usually fine. Patient is post-operative or some intoxication or something. Lungs are good. Only CO2 control is required. Then volume is good. Then comes white X-ray, pressure. White and black X-ray, again pressure. Next one. Next one. So these are fine. This coming. Fine. So black X-ray. Now black X-ray means what? Typical thing is actually bronchiolitis. In bronchiolitis, if you try to ventilate by pressure, you must have seen CO2 goes up very high. Initially CO2 was 80. After intubation, CO2 goes to 120 actually. Because this pressure is actually targeted, can lead to further gas trapping. But this volume ventilation is very good as far as this black X-ray is concerned. Peritubal leak is present, then better to ventilate by pressure rather than volume. Then bronchomalacia, bronchospasm, hypoxia dominant, this one actually the same thing we control. So these are the summary of it. Now, what is the basis of it? These are the it is very oversimplification actually. I am sorry for that, but I will try to explain it afterwards. Next one. HI with clear lungs, volume limited. Severe RDS, pressure limited. Bronchiolitis, again volume. Improving lungs with vulnerable brain, again volume. Severe pneumonia, pressure. Next one. So this is the graph. Only graph will use this one. So in this graph, this one first is pressure and there is volume. Now pressure we can see this controlled PIP. So in this particular thing we can see that this particular PIP is going up and down like this. So it is pressure is constant. Pressure is constant. Volume is variable. Volume can change. Volume can change, but this pressure limit is constant. This is typically seen in pressure. Now we can see the square forms, and here there are actually slowly rising volume, this one, and is changing. Now let's compare what happens with volume. Next one. So volume, what happens? This one. This volume, what happens is that this pressure control, this one, this PIP raise and then comes down, ramp like, and this volume is actually square. So what is the this one? What is the summary? Because many times what happens, these graphics are very difficult to understand sometimes. Next slide. So previous slide. So to make it simple, this pressure limited, what happens is that our whole idea is to limit pressure. Means, suppose if you tell the ventilator you have to give PIP of 15. Now this particular flow, this respiration will continue, inspiration will continue till 15 is achieved, and at that time it won't allow this to cross 15. Now this particular thing can be achieved with various volumes. Volume will change, pressure won't change. This is pressure. Volume limited, volume targeted, not limited, volume targeted. So the same volume will be given, but variable pressures. Now this variable pressure is very beautiful advantage of volume. What happens is that there are two words in treatment. Patient is needing ventilator. Patient is needing ventilator. Patient is needing PIP of 20. This particular somebody junior tells me, I get very angry. You are giving 20 does not mean that patient is needing 20. You are giving 30, that does not mean patient is needing 30. It's very different, very different. Patient needs 20 pressure and we are giving 20 pressure is different. Now, whether how much pressure it needs is told by volume ventilation. So, suppose if you put a volume and patient is getting 20, that means he is needing 20. On a pressure, we are giving 20, is I don't know whether he really needs 20 or not. That is the most important difference between volume and pressure. That's why volume is supposed to be better than pressure as far as lung protective strategy is concerned. Unnecessary pressures are not given. The pressure decided by machine, not by you, based on volume fed by you. So, if the pressure requirement is little, suppose PEP fixed at 5, now already we have putting 5 cc per kg volume, tidal volume, and PIP is coming up to only 12. That means this patient is ready for extubation. If the PIP requiring is crossing 16, 18, that means there is some problem. The pressure requirement is rising. In that case, maybe the mode is fade. Let us shift it to pressure limited. Or suppose it keeps crossing further, we can shift it to HFO. So there are various schools of thought. Some people they volume to shift to pressure. Some people volume they shift to HFOV also. Those centers who use volume liberally, they use HF also liberally. Because of volume, there is a lot of atelectasis. That's why HFO works wonders there. So volume, usually they have got inborn babies, they ventilate baby early, the outcomes are good, but their HFO use is more. Pressure, usually outborn babies, usually they get babies late, non-homogeneous, non-pulmonary problems, oxygenation problems, and their outcomes are moderate. So we can't compare apple with oranges. These are two different things. So as far as pressure is concerned, volume is concerned, they are different. When you got typical baby for volume is where young extreme preterm baby with vulnerable brain who is having improving lungs, maybe abnormal brain, and where CO2 control is important. X-rays are good actually relatively. They are having tachypnea more than distress. Pressure, typical baby is a tough ventilation, white lungs, pulmonary hemorrhage, pneumothorax, severe collapses, atelectasis happening. This is pressure. Oxygenation problem, pressure. Developing severe RDS, pressure. Surfactant failure, pressure. So these are the typical, there are two different situations, they are overlapping. But the once you understand telling that one baby can be on pressure sometimes, can be on volume sometimes. This baby can be on pressure, this baby can be volume. The percentage can change depending on your demographics. So next one. Now let us see some evidence behind it. Next one. So what is the evidence? What we'll do, directly we'll go to animal experiments, directly we'll go to most recent evidence. This is animal experiment, very famous animal experiment. What is there? Pressure trauma, barotrauma is more risky or volume trauma is more risky. They observed that volume trauma is worse than pressure, barotrauma. What they did is that they strapped the animal's chest and gave this one pressures, and whether this change is more dangerous or high pressure with less change is more dangerous. high pressure with less change, low pressure with more change. They observed that lower pressure with more change was worse. So this is actually prevented by volume ventilation. This commonly happens in pressure ventilation. So they concluded that volume is better than pressure. But this trapping of lung is experimental. It is not real life. Next one. So these are the these are the changes, meta-analysis and all those things. There are earlier meta-analysis which was done earlier. They actually have very small studies actually, and they were not actually relevant to our practice because they were actually considered different actually type of population, and they said that volume is good. And surprisingly, the countries who reported these studies, there also pressure is practiced more than volume. Sometimes people talk differently in conferences, they do differently in their own analysis. Similarly, the still neonatal ventilation mainstay is continues to be pressure. Slowly, volume is increasing. My main attention request to everybody is individualize the patient. Don't say volume is better or pressure is better. We can say volume is better, pressure is better in this baby, not in all babies. Next one. One more. We'll go to directly last this one. Next one. This is the cutting edge, because now previously there was a time when 1.5 kg baby was the average baby on ventilator. It became 1 kg, then it became 750 gram. Now it is 500 gram. 22 to 25 weeks. That is our final frontier. If we are able to ventilate these babies, that means we are done. And other countries are going through that phase. We are also going through that phase. Now this 22 to 25 week gestation age, early volume targeted ventilation, and they compared with pressure ventilation. And what they observed is this: IVH grade 3, BPD, time on mechanical ventilation did not differ between the groups. So when actually it is a very most difficult ventilation is there, and that this particular group is some group where lungs cannot be normal at all. Lungs are definitely abnormal. They are having severe surfactant deficiency, where volume and pressure is same. So pressure and volume both have got advantages, disadvantages, and we have to choose wisely. Next one. Can you? Now, this particular part we will discuss in workshop. Just is a primer. This is a primer. Just what we can say, a lot of figures. So many figures. This one. What happens now? These figures usually confuse us. These so many figures. Why I kept it? Just to know that there is no single figure. What is this figure? 4.4 is the average tidal volume of a spontaneously breathing baby on CPAP. Average tidal volume of a spontaneously breathing baby on CPAP, 4.4 ml per kg. Range is 6 to 7.2, such a wide. So in the same study, range was 2.6 to 7.2. So whatever volume you are giving, 4 ml per kg, 5 ml per kg, may be adequate or excessive depending on CO2. CO2 is the king here. In volume ventilation, CO2 is the king. Don't try to go beyond 8 as far as possible. Those who have gone beyond 8, they found that cytokine levels are more. That means biotrauma increases if you go beyond 8. But sometimes we have to go beyond 8. Why? In chronic ventilation, long-standing ventilation, there is dilatation of airway. And this airway steals the volume. So dead space increases. So dead space is anemia of volume ventilation. Whenever there is increase in dead space, actually there is a failure of volume ventilation. So more than 8, very rarely you practice in those conditions where actually we go for 1 month, 2 month, 3 month chronic lung disease. Otherwise, try to keep the volume cc per kg less than 8. Don't go below 3. Don't go below 3. Can you stop the phone? Don't go below 3. If you go below 3, they have observed that a lot of collapses, atelectasis happens. Now, what is this based on this one? Based on this study. This we know for sure. Dead space in neonate is 2 to 2.5 cc per kg. 2 to 2.5 cc per kg is dead space. So multiplied by 2. Now what we get is 4 to 5. So rule of thumb is roughly take 4 to 5 cc per kg per breath in volume ventilation. Now whether 4 or 5. Now here smaller the baby, use higher number. Bigger the baby, use smaller number. So once you get 308 grams, recently when you did 308 gram baby, in that case we can go for 5. And suppose if you get 1.2 kilo, ventilate with 4. So smaller the baby, bigger the number, bigger the baby, smaller the number. And what is 0.5? increments and decrements should be done with 0.5. PIP decrement with 2. PP increment with 1. Similarly, volume all changes happen with 0.5. And 4 to 6 is rough. Though we are saying 4 to 5, the freedom is not equal on both sides. 4, the limit is 3 quite nearby. But here for 5, limit is 5, 6, 7, 8. Remember that. Suppose CO2 washout happening with 4 only, that means actually at pressure requirement will be less, baby is fit for extubation. Don't actually reduce too much this side, but you can increase further. The freedom or leeway is more for increasing, not much for decreasing. These are the practical points. All these things we can discuss in workstations. In this talk, we focus predominantly on not knowing actually what is better, individualizing the baby, and roughly what are the settings on volume ventilation. Thank you. Thanks a lot.
Okay, good afternoon everybody. So after two fantastic talks by Dr. Rahul and Dr. Saravanan, so you guys have got a feel of that how the ventilation is going on, what are the modes of ventilation, and when to choose pressure, when to choose volume. Now, when you are ventilating a baby, you have 2-3 options. One option is that you look at the baby. Suppose you ventilate the baby because of increased work of breathing. What is the most common indication when we ventilate the baby? Increased work of breathing, right? So baby is having distress, baby is desaturating. You put the baby on ventilator and you find that the baby is better. Baby is better. His heart rate was more, now his heart rate has settled down. Respiratory rate was more, it has settled down. Breathing difficulty was there, now the baby is pink, perfused. So this is how you feel that, okay, my ventilation is working. So based on which we can say that whether we are doing good thing or we are it's not just, it's about doing the gentler ventilation. So nowadays ventilators, they are equipped with pulmonary graphics. So how does pulmonary graphics help us in deciding that whatever we are doing right? So that's the crux of this talk. So how can we assess the adequacy of ventilation? One is by the clinical, that your baby gets better. One is you see on the monitor the child is having better saturations. You do a blood gas, it is the PCO2 is better, the pH is better, and then the thing about real time pulmonary graphics. So for learning about real time pulmonary graphics, in the last presentation also you have seen that you have seen the waveform. But what is there in the ventilator circuit which will tell you, or which is the most essential thing, so that the graphics they come to your screen? That is the flow sensor. Okay. So first and foremost message is that when you are ventilating a child, your flow sensor should be properly calibrated. You should not be just happy by putting the baby on assist control or SIMV mode, and if your flow sensor is not working, the ventilation switches back to the CMV mode or the IMV mode. Means synchronization or whatever the baby is taking, the calculation of flow, the calculation of volume, it is done by this entity which is called the flow sensor. So pointer is not working, but normally in flow sensor, so they work on different things, but these flow sensors usually have a heated wire anemometer. So there is an element there, when the flow passes across it, there is a temperature change and which the ventilator actually senses. So this flow sensor, normally in neonatal ventilation, it is near to the T-piece, it is near to the place where the endotracheal tube tip is attached to the ventilator circuit. In adult ventilators, it is usually inside the ventilator machine. So in adult ventilators, you can see that, or you know that the tidal volume is too much, like in one breath we are taking 500 ml of volume, and the circuit which is there, the circuit volume loss or the compressible volume loss is not much. as compared to 500 ml. But for a 1 kilo baby, in the last talk, it was mentioned that 4 to 6 ml is the tidal volume. So it's only 5 ml. So if the flow sensor is inside the machine, that may be lost. So to calculate the volume and flows precisely, your flow sensor should be near the tip of the endotracheal tube, A, and B, it should not be alarming, it should be calibrated. So this is first and foremost thing. Okay. Okay, so why pulmonary graphics? I think from here it is easier. Sorry. So why pulmonary graphics? So your purpose of putting the baby on ventilator is gentler ventilation, so you can optimize ventilation depending on the graphics. So people say that if you are not looking at the graphics, it's like you are working on a computer, but there is no monitor. Whatever you are doing, it comes to the place when you are looking at the graphics. So you can optimize the setting. Sometimes the tube is displaced, you are in a dilemma because the baby is breathing normally also, whether the tube is in normal place or not. Sometimes there is leak around the tube, sometimes there are secretions in the circuit. So many times it helps you to tell why your baby is desaturating or why your baby is not behaving well. So the graphics are defined as direct real-time visualization of fundamental vectors of the respiratory support. That is the airflow, pressure and the volume. So there are two types of graphics which you will see universally. So one is the scalar. In scalar one, on the x-axis there is time, and on the y-axis there is a variable. That variable can be pressure, that variable can be volume, that variable can be flow. When one variable is plotted against the another variable, then becomes the loop waveform. The most commonly used are the pressure and volume loop or the flow and volume loop. So this is the scalar waveform. Normally from the ventilator to ventilator screen it may change, but the topmost is the pressure one. On the x-axis is the time, on the y-axis is the pressure. The middle one is the flow one, on the x-axis is the time, and the y-axis is the thing which is above the line is the inspiratory flow. So that's the inspiratory flow and that's the expiratory flow. Okay, and the lowermost is the volume one. So volume, this is the inspiration and this is okay. Let's go one by one. So on the y-axis is the pressure, on the x-axis is the time, right? So this graph monitors the changes in the pressure which is happening against the time. So after first talk, a question to any of you: what does the area under curve in a pressure and time waveform tells us? Mean airway pressure, right? So first and foremost is that we should understand that how this pressure airway curve is, pressure time scalar waveform is generated. So the baseline, this is the PEEP. Okay, so this is the pressure which is there throughout the respiratory cycle, whether it's the inspiration or the expiration. So when the inspiratory cycle begins, like from here, the breath starts. So this is the place where the breath is triggered. It goes up and it goes up till the time, if it's a pressure limited cycle, your pressure is achieved, your PIP is achieved. Suppose the PEEP was 6, so the baseline is 6 and you have put a PIP of 20, so there the 20 is achieved. Now when this 20 is achieved, suppose your TI is 0.3 second, this 20 is achieved in 0.1 second. So till 0.3 second, because the inspiration has to go on, so the same pressure will be maintained in the respiratory cycle till 0.3 second. And at 0.3 second, the expiratory valve opens up and the breath goes into expiration, and with the elastic recoil of the lung, this is the expiration. So this same thing keeps on happening. Okay. So one clinical application is, as you rightly mentioned, is that area under the curve is mean airway pressure. So whenever a baby is, so what are the two parameters which determine oxygenation when your baby is on conventional ventilation? FiO2 and MAP, right? So FiO2, suppose your baby is desaturating and you have pumped up the FiO2 to 80% or 100%. So the next thing is MAP. So how you can increase the MAP? This graph automatically tells you, right? So first and foremost is you can lift up the baseline by increasing the PWP. Okay. Then you can lift up this thing by increasing the PIP. Then third is you can try to achieve this PIP earlier. So if this line is like this, one is like this, and one is like this. So which one it is achieving earlier? When the slant is lesser, when it is, so by that also you will increase the, and that you can shift this line here by increasing the flow. There are some ventilators in which adjust the flows, but there are some ventilators nowadays which comes in which you cannot adjust the flow, the machine is only doing the job. Another is, suppose you increase this point, you bring here, then also the area will increase. And how you can do that? By increasing the TI. So you can increase the TI. So all these things, they have their benefits as well as drawbacks. Important is to understand that what is baby and which is the parameter which you want to increase. Suppose your baby has got a white lung and he is desaturating, so you would like to tend to increase the PWP open up. Suppose he is having a tidal volume which is very less, it is 2 or 3 ml per kg, and your PCO2s are 80, right? You will try to increase the PIP. So these are guidelines, not that, but this something time. The flow waveform will tell you whether your TI is adequate or not. Okay. So what is there in this graph? This is a pressure. Sorry. Okay. Time. See the PIP. Right, you don't want that. So you want the alveoli to get recruited. So if the PIP is achieved in when finishing, then all the alveoli, they will not get recruited. Okay. The flow is too low. Okay. What is happening here? It's too high flow. So your waveform is a square waveform. And what is the drawback if the flow is too high? Everybody, what is the drawback if the flow is too high? Trauma, how? So A pressure is achieved earlier. If the flow is too much, then it will generate turbulence in the circuit. And if the turbulence in the circuit, the resistance will increase or decrease? Resistance will increase, right? So resistance will increase. So resistance to the flow of gases will increase. So this is like what we call as adequate TI. PIP is achieved in the one third of the TI. It's called adequate flow. So that's how. So there are two clinical applications of the pressure time waveform. The first application is you can decide about the map, and if you have to increase the map, you can look for that. And second is that you can at how the flow pattern, how the waveform is looking. So I haven't done too much depth in. Sometimes you can even assess the synchronization also, but there are better waveforms to do that. So we will stick to that easier thing. So this is, I think, the uppermost is the pressure, that how the waveform is changing. So the map here is coming 7.5, and as you see, so you increase the PIP, map is increasing, and your waveform is getting taller, then your baseline is shifting up, so the map is further increasing, and then in this you cannot, because this machine you cannot adjust the flow. The third thing is you increase the TI. So here we have increased the TI, and if you can see that in the inspiratory and the expiratory there is widening. That's how your map is increased. Increase your pressure when your field is desaturating. Can you please press next slide? It's not pressing. Okay. the thing which is line is the inspiratory flow, thing which is down the baseline is the expiratory flow. Expiratory flow normally what in the inspiration, somewhere in the middle of the inspiration, the flow starts declining because the pressure has been equalized, and at the end of the inspiration there is no flow because the pressure in the airway and pressure in the alveoli is similar. So there is no flow is needed. Then when after the TI, when the machine stops giving pressure because of the elastic recoil of the lungs, expiration happens. Similarly, in the first part of the expiration, the flow is so as to expel, and then the flow decelerates, and at the end of expiration it again comes back to 0. So sometime you can have a inspiratory time in which, so before your inspiration is ending, your expiration is starting. What is the fault of short TI? Anybody? If the TI is too short, suppose your baby TI of 0.3 seconds, in the first talk you understood that TI is decided by compliance and resistance, time constant, and that TI should be 3 to 5 times time constant. Suppose you have put it too low, what is the risk? So, good. The alveoli, they will not be recruited, right? So, eventually your child will start deoxygenating. So, your TI should be appropriate. Is the inspiratory is okay, but look at the expiratory one. So before this should have reached here, the next inspiration starts. So suppose you have kept a rate of 100, right? You have kept a rate of 100 and TI is 0.5. So then your TI is too short. And if the TI is too short, what problem will happen? Air trapping, very good. So generation of auto PEEP, eventually it can lead to pneumothorax. Air leak will happen. So these your waveforms, they will tell you whether your TI is too short or not, whether your TI is too short. Okay. So what is happening here? It's a very long TI. So of the lung, the inspiration is ending here. Is ending here, but you have, suppose this was 0.3 and you have kept a TI of 0.5. So second, machine will keep on giving pressure so that the baby can't expire. After 0.5 seconds, the baby will expire when the machine stops giving pressure. So the baby needs a TI of 0.3, but you have kept a TI of 0.5. So what is the harm? What harm it can lead to? Long for barotrauma, tracheobronchitis, even time air leaks also. Okay. So unnecessarily high long TI should not be there. So what you will do, you will decrease the TI and your waveform should look like this. This is the adequate TI. Can you play on the next slide, because it's not okay. So this is how your adequate TI should be, the inspiration, the expiration. So flow waveform, clinical application, you can see that when the margin is there between the inspiration and the expiration, then the TI is too long. And when you decrease the TI, then you can see that there is no difference between the inspiration and the expiration. This is how this should be. The third waveform is the volume scalar waveform. On the y-axis is the volume, on the x-axis is the time. Okay. So in volume also there is an inspiration and then expiration, right? So what is happening here? The inspiration is complete, but the expiration is not coming to the baseline. Anybody, what is happening here? No, it's not air trapping. The volume in which, so basically the inspiration is complete, but the expiration is not there. This is leak happening. When there is a leak, so flow sensor is basically not calculated. Try to understand. So the whatever is lesser than what was going inside. So where has the remaining gone? It has gone into the peritubal leak. So if the leak increases, suppose this is 20%, if the leak is 30-40%, this line will come here only. If the leak is 100%, then it is not coming back. We will show you. What's happening? Third waveform is the volume 1, right? In volume, this is the inspiration, and expiration it's not returning back. What is happening? Leak. You can see that the leak, I think, it's not coming. But it's a very significant leak. Similarly, look at the flow. This flow is okay, and when the leak is happening, when the flow waveform, what is happening to the inspiratory flow? See, inspiratory flow, it's not coming to the baseline. The expiratory flows are too less. So even you can train your nurses also that in the middle of the night, if the baby is desaturating and they look at these two waveforms, this is so much informative that by looking at the flow waveform only, they can judge whether there is leak or not, and they can judge for the placement. If the suppose accidentally the tube is displaced from trachea into esophagus, what will happen to this waveform? Anybody? So there will be only inspiration, there will be no expiratory flow. So you will not see anything below the baseline. So if she is seeing that everything is on the above only, neither it is coming back, so that means the tube is displaced, your baby is desaturating, it is time that you need to re-intubate. Okay. So till now, summarizing the clinical applications, pressure waveform was the mean airway pressure, and you can look for that how to increase the mean airway pressure. And the other, what was the other application we found in the pressure one? What was the other? So mean airway pressure. In flow waveform, TI, it should be adequate, long TI, short TE leading to gas trapping. Then the volume one and the flow one, you can look for the leak, and the flow one also will tell you, or the volume one will tell you either whether your tube is displaced or not, right? Okay. Now coming to the loop waveform. So in loop, in the starting we told you that loop is when one variable is plotted against the other variable, right? When one variable is plotted against the other variable. This is a scalar waveform of pressure. So these are the loop waveforms. This one, the pressure is plotted against the volume. By convention, on the x-axis is the pressure and on the y-axis is the volume. Okay. By convention, on the x-axis is the pressure, y-axis is the volume, and in this flow volume loop, you are on the y-axis is the flow and x-axis is the volume. So somehow, I mean, this is the ventilator, so you have to remember and you imagine it by this way. We are going to discuss about the pressure volume. So on the x-axis is the pressure, on the y-axis is the volume. So when the breath starts, what is happening is, so when the breath starts, actually it's difficult without a pointer. So when the breath starts, it doesn't start from the zero pressure. It always starts from a pressure PWP, which is always there, So suppose you have set a PWP of 5 or 6, the inspiration will start. So this one is the inspiration. This one is the inspiration, right? So this is the inspiration. So inspiration will start from the PWP, right? Then in the alveoli, the pressure is going to deliver the tidal volume. So pressure is building up. There will be a point. Okay, what is compliance? I am going back from advanced to basic. What is compliance? Volume change? Very good. So change in volume per unit change in pressure. Okay. So suppose by changing 5 units of pressure, there is one scenario in which only 1 ml tidal volume is generated. Another scenario is 5 units change in pressure, 5 ml tidal volume is generated. Compliance is poor in which part? where the tidal volume was 1 ml, right? So the compliance curve will be flattened, okay, and the compliance curve will be steep like in this direction, when a little bit of change in pressure leads to good change in volume. So there is an entity which is called critical opening pressure. That critical opening pressure is the pressure at which the alveoli opens up, and after that little bit change in pressure will lead to significant change in volume. That's what we want, okay. And the art in ventilation is actually to find out that critical opening pressure. It's not so simple, but gentler ventilation and optimizing the PWP is if you can find out the critical opening pressure. So like here in this, basically, so initial part, the pressure, this pressure change is this much and the volume change is small, but after critical opening pressure there is a steep rise, right? There is a steep rise, and then the inspiration ends there. So that's the point where inspiration is end, and then the breath goes into expiration, okay. And this curve is called compliance curve. This is the resistance which is encountered during the inspiration, and this is the resistance which is encountered during the expiration. Resistance, this was because of the elastic thing, compliance, and this resistance. So because of this, if there would have been no resistance, then it would have been a straight line. The loop is formed because of the resistance, and that is called hysteresis. If we increase the resistance, then this hysteresis will widen up. Compliance is very poor, like before giving surfactant, this is narrow. So you can start observing a preterm baby, 700, 800 grammer, RDS, you observe the loop, you give the surfactant, you will see the hysteresis has widened up. Not only the compliance will improve. Before giving surfactant, your graph is a flatter graph. After giving surfactant, it will go up steeper because the compliance is improved. Lesser PWP, your graph is a flat graph. Good or adequate PWP, your graph is a steeper graph. Excessive PWP, then your graph will go in which direction? More this direction? No. If excessive PWP, then again the compliance is poor. If suppose the child needs a PWP of 6 and you have given a PWP of 9, again the change in volume per unit change in pressure will be bad, because the lungs are hyper expanded now, right? Alveoli are hyper inflated. So then again your graph will be flat, okay. So there is no condition in newborns in which the compliance is more. Compliance can be normal or it can be low. In adults like emphysema etc. are the conditions where the compliance is more. Does it make little bit of sense? So the next one is the flow volume loop, in which on the y-axis is the flow and on the x-axis is the volume. So it moves in the clockwise direction. So it starts from here, from the zero flow. In the inspiration the flow peaks up, and then as we discussed it comes to baseline. Then expiration, elastic recoil, again the flows go, it peaks up, and then at the end of expiration the flow comes to 0, okay. So these two were normal graphs. We will see that what happens in different conditions. Shall I go ahead? So application is assessing leak. Assessing leak we saw in the scalar waveform also. In the scalar, which were the two waveforms which were telling us about the leak? Flow, and the second one is volume. Flow and volume. Optimizing PWP, we will see how. Optimizing TI and the synchrony and the tube block. Okay. So now here is, this is inspiration. Down here, what is this happening? This is peritubal leak, not pneumothorax. This is leak which is happening. So whatever inspiration has gone, if the expiration is not coming to the baseline or not connecting here, that defect is the leak. Similarly, on the flow volume, you see that inspiratory flows are full, but the expiratory flows, the expiratory flow should have come here, but the expiratory flow is finishing leak. by flow and volume, and this is so easy, right? Time the leak is happening and you do a minor change in the position of the endotracheal tube, minor change in the position of the neck, see that the leak subsides, right? And your child will start saturating better. So by minimal things, so by looking at, so basics of pulmonary graphics talk is that you can identify simpler things, and sometimes you don't need to subject the child to too much interventions. Again, see the leak is lesser, in that leak was more. So this is inspiration, this is expiration, and the leak is around 12-14% only. Flow waveform, this is inspiration, this is expiration, it's not getting back here, but so if it is approaching near this, then the leak is lesser. If it is would have finished here, then the leak was more. Okay. So similarly here, inspiration and expiration, if the expiration and inspiration the gap is more, then the leak is more. See, if it's a more leak, it's around 80-90% leak. Look at the inspiration and expiration, where the expiration is ending in the pressure volume loop, and in the flow volume loop, look at the inspiration and expiration where it is ending. So leak is something at least which you can identify very easily if you. So now what to do when scenario? What to do is you can take the child on a self-inflating bag or the T-piece resuscitator and tie test lung to the ventilator circuit, and you see that whether with the application of test lung again the leak is that much only or not. If applying test lung the leak is still 80%, it was 80% previously and it is 80%, then that's a true leak. But sometimes the flow sensor is faulty, sometimes there is water in circuit, and these all things can lead to the flow sensor, if it is faulty, it may calculate the leak more. So on the safer side, you before changing the tube, you should do this maneuver. If you find that on the test lung also the leak is that much only, then you should change the endotracheal tube. So if leak is present on the test lung, check all the circuit connections. So sometimes some circuit connection, some connection has been disconnected, because of that leak is coming. You can recalibrate the flow sensor, and if child still not improving, then you can change the endotracheal tube. Okay. So what is in this graph? Let's start from the inspiration. So the PWP set is this much. Okay. Let's imagine this is 3. Fine. Now PIP has started from going from 3 to 10. Is there a volume change? Going from 3 to 10, is there a volume change? Yes or no? No. Zero volume change. So that means that if the alveoli was collapsed like this at a pressure of 3, from 3 to 10 there have been no volume change. Then the 10 is the place where it's a critical opening pressure, where the alveoli opens up, and now the pressure change will lead to the volume change. Okay. Now the pressure change will lead to the volume change. Okay. And then it goes into expiration. Okay. So what will you see if you see that the graph is like this? Increase the PWP. So increase the PWP and you will try to shorten this. So in heterogeneous lung diseases, in severe lung diseases, pneumonia, meconium aspiration, it's not such a easy ball game like what I am saying. It's not always possible that we can omit this thing, right? But if mainly in RDS, if we can omit this thing, or in those lung diseases, this part is shorter, so that means your VQ mismatch is lesser, your ventilation is gentler, okay, your PWP is adequate. So by looking at the loop waveform, you can optimize the PEEP, right? So we increase the PEEP and let's see the waveform gets better. Okay. So again the same thing. So what we need to do is increase the PWP. Okay, what is happening here? Anybody? Look at that circle. Anybody? PIP is more. So that's what is happening in the beaking. So in the last part of the PIP, suppose I say that PWP is 6 and PIP is 25. So till it's just imagination, till 21, 22 there is a volume change. But in the last part of the PIP there is no volume change. So that means it's an excessive PIP. So you will try to decrease the PIP and you will try to abolish this beaking. It is called beaking. Okay. Then when this happens in flow starvation. Child is breathing at very fast rates, your flow is inadequate. So you need to, this is called figure of 8, and you need to increase the flow. In ventilators, where you cannot adjust the flows, this is rarely happens. This happens when the child is fighting too much or child is breathing too fast. Okay. Okay, let's look at the sum of the flow waveforms problem. If the flow waveform is like this, flow and volume loop is like this. So flow volume loop is like this, it's like square shape. It's when the resistance is increased, when the extrathoracic resistance is increased. Extrathoracic resistance is increased when it's a subglottic stenosis or your tube size is too less. The child needs a tube size of 3.5 and you have put a tube size of 2.5. Then the inspiration and expiration, both the flows are lesser. Okay. So effect of elevated resistance, let's see. Sir, can you play this video? Here, click here. Okay. So look at both the things, hysteresis and that. So when we increase the resistance, then the hysteresis get widened up. If you remember that compliance line where I was telling you about R1 and R2, the resistance is increased, so the loop has widened up. And what has happened to the flow volume waveform? This is normal, and when the resistance will be increased, the flow will be lesser. See? So by this is on a test lung. When we have tried to increase the resistance, we will see we will do all this exercise in the workstation. By doing that, it happens like this. So sometimes if you find that suppose previously the waveform were looking normal and now the flow volume loop are abnormal and the pressure volume loop, the hysteresis is widened up, you can think that there may be somewhere kinking in the endotracheal tube. Okay, there may be sometimes the endotracheal tube is too small in size, so you can think about that. So sometimes the upper one is the inspiratory, which is okay. The expiratory, the resistance is increased. In the expiratory, this is the expiratory part. In the expiratory part, the flow increases, and then while returning to the baseline, it follows this curve, which is because of the increased resistance which is seen in BPD. It's too late. 5 minutes more just. It's like this. When there is in the inspiratory part, there is this. This is because of any guesses? Very nice. Excellent. Excellent. So water in the tube will lead to this. Okay. Anything which is happening here? So if only intrathoracic obstruction is there, this is sometimes we don't see commonly, but intrathoracic obstruction can be seen in pneumothorax cases. Okay. Then this is we have discussed, leak. Okay. Again now inspiration, the flow is there, it's not coming back here. What is there? What is happening? Sorry, tube out. Very good. So it's expiration. And here it's like the hole is the juggle. What is this? Sorry, blunder. Water, no, water was the mainly inspiration. It can be both inspiration, expiration also. Water can be possibility, but many a times in tracheomalacia, this kind of pattern you will see when you have a vulnerable airway. Okay, so, what is happening?
Slide
It's too much of. Okay.
approach.
Sir, can you play the video, please? So in this we have tried to adjust for the pneumothorax, and you will see that how the signs of intrathoracic obstruction appears.
It is
So we
important
will
to
discuss this in the workstation also.
pain management is
So basically you will
for
see
the
that the
parents.
compliance get
Okay, so
lessens up. Its compliance was
you-
1.05 and now the compliance has decreased to 0.68 or 0.7. So on your nursing monitoring sheet, it is actually important if the nurse is mentioning the compliance. When you come and the child is desaturating, you can see, look for the compliance. If it has decreased, you can think, okay, collapse has happened up, or the pneumothorax has happened up.
one particular time. You don't repeatedly prick the baby.
So
on
this
one
is a
particular
single lung
time.
ventilation. When both the lungs are ventilating, the compliance is good,
non-invasive tools like
and then again the
transcutaneous
compliance
beta
drops
meter
when
for,
it's a
assessing
single lung ventilation we do. So we will discuss this more in the workstation, sir. Can
ecological
you
method
next
for,
slide, please?
for slightly more severe, I would say a moderate
Okay.
pain. It's
So
not very severe,
any
but
guesses
moderate
what is
pain
happening
can be,
here? So I tell
treated
you,
very effectively with
pressure, flow,
So
volume, right? The respiratory
uh,
rate was set at
indicated
60
in
breaths
very
per
severe
minute,
pain,
and
the
baby is
TT
breathing right
doctors
now
will
at a
give the
rate of
orders for
120
starting
breaths per
these
minute.
particular medications.
Not baby is breathing, the machine is
So,
giving 120 breaths per minute.
Pharmacological management of pain. So this
Autocycling.
is
Have you heard about
self-explanatory,
autocycling?
clustered care. So
So
that means
autocycling
grouping
is,
all your
if there is water in the circuit
interventions
or if
to
there is a
the baby,
peritubal leak,
uh,
what happens is
in
the
one
flow
per- in
sensor
one point of
will judge
like this
movements in the changes in the
all these
flow
things
as
in
the
half an
breath
hour.
initiated by the baby. If there is too
PG.
much water in the inspiratory circuit, when
The
the
same
flow is
thing if
going on, although it's in the single inspiration it is going on, but the flow sensor may calculate its first breath, second breath. And in synchronized mode like SIPPV or pressure support, where all the breaths which are initiated by the baby are synchronized by the machine, fully assisted by the machine, then the machine starts assisting every breath.
The second
Right?
non-pharmacological
Similar thing happen when the tubal leak
fundamental
is too much. So when the peritubal leak is more than 30% or 40%, then also autocycling may happen. So autocycling was one used to be considered a major drawback of pressure support ventilation. So in autocycling, you can see that the breath is coming after. All of them are fully supported because the baby is on either pressure support ventilation mode or assist control or SIPPV mode, and there it usually happens because of excessive tubal leak or water in the circuit. Okay.
So units also practice cycled lights are on during some
Okay.
of the day.
What is happening here?
Dimmed in other times of the day. Do you practice that in
This
your
is
units?
easier.
Cycle lightings.
What is happening?
So the lights are on during some time and then dim during periodic,
Because of, very good.
which is
So because
good
of
for the
secretions in the endotracheal tube, the expiratory flow,
if you
expiratory
have dim
flow,
light in the
there is a slurring which happens. So you need to do the suctioning. This I think we have discussed, the tracheomalacia, water, everything in this. Okay, this I think it's just for revision we have discussed. The problem here, this is a flow scalar wave, long TI, short TI, it's a long TI. See, the flow has stopped here, but the expiration is happening from here. So the TI is too long. So you will decrease the TI so that there will be no gap between the. So mode, which is the mode in which there can be never be difference between the inspiration and expiration flow waveform. Out of all the modes of ventilator, there is one mode in which the baby decides his own inspiratory time. So when the baby is deciding his own inspiratory time, there cannot be a inspiratory and expiratory flow waveform. Pressure support ventilation. Okay, so I think we will decrease the TI here and then things will get sorted out. So this is when the inadequate expiration is not fully happening and the inspiration is starting. So
facilitated
this is short,
this is a facilitated tucking in the
not short TE, which can lead to
posture.
air
Basically
trapping.
what you need to do is you need to make sure that the head, the the upper limbs, the lower
So these
limbs,
are the last two
and the trunk
slides.
are all enough flexed.
So I think they have shown
In
you,
this
also.
picture, you see soft
So this is a CMV breast.
that are in
No,
the shape
this
of
is not
gloves that are
SIMV.
supporting the baby's
Sorry.
head.
We will discuss it more there.
This is the
So
position which the
basically
baby is
what I
going to
wanted
be
to
in
show
when
here
they
is
are
SIPPV or assist control mode.
very
You can
comfortable
see
for
that
the baby.
all the breaths are of same tidal volume,
Position.
because every
Kangaroo
breath
care,
which
skin,
is triggered by the
is
baby is being
adjusted
fully supported by the machine.
reducing pain
In
and
SIPPV,
babies, because
there
the
will be
baby's
mandatory
hormones
breaths
that
will be of good
increase the
tidal volume,
contraction.
but the breath which will be taken by the baby,
So
apart
other
from the
methods
mandatory
are,
breath, they will be of the
non-neoprotective
lesser
sucking,
tidal volume.
where the baby is allowed to
I think we can
feed on an
finish it
empty
off.
breast, probably during
Okay,
the procedure or
change the next
immediately
slide.
after a procedure. It's oral sucrose 24%.
Okay. So coming to the last two slides, use of graphic optimizing setting, PIP, the tidal volume sensor will tell you 4 to 6 ml per kg. Dr. Rahul in the last talk, he told you loops that does under distension or over distension, airflow in the pressure scalar waveform. If the rising time is 1/3 of the TI, then that is appropriate. Also, the asynchrony results from a flow sensor that needs calibration, water in the circuit, secretions in the tube, or child is in pain or discomfort, and you take care of that. So overall, pulmonary graphics, it's a useful adjunct to the clinical assessment. But one thing, there is as such no evidence that use of graphics leads to better outcome. But it doesn't replaces the clinical assessment. Always clinical assessment is always takes precedence over the graphics, and ventilation without the use it's possible. Thank you. Thank you. Any questions if you want to ask? Yeah, assist control SIPPV is same, and in some machines it is by name of PTV also, patient triggered ventilation. CMV is IMV, controlled mandatory ventilation, no synchronization. Yeah, very nice.
Thank you, Dr. Naveen. It was exhaustive and it was quite interactive, especially these videos and all. You won't get it anywhere else. So it is really one of the best talks that I'll make. Naveen. So the next session. Super.
Can I take this? Thank you. I will give you.
Saturation. Basically, you mix.
Sure. So I think can I have my slides, please? Okay. Okay. So it's good to have your babies on ventilator, but it's to have your babies on ventilator for very for mechanical ventilation goes up. Given an option over a period of time, you do not want to have invasive ventilator in your. Given a choice, you would say, I don't want. It will be for your babies and for yourself. You are more relaxed when babies are CPAP than ventilator. The reason being, yes, ventilation comes at a cost. At least in our country, it comes with a major cost. One of your major worries, definitely morbidities associated with invasive ventilation. So best possible, avoid invasive ventilation whenever possible. Try your level best, CPAP, HFNC, and whatever you want to do it. Try your level best not to go on to ventilator, because ventilator always comes with a cost. What are the three major concerns that you have if the baby is on a ventilator? Whatever the best ventilators, you might have the best of the ventilators seen from me. All these ventilators, all this invasive ventilation comes with cost, and the cost you pay is, in our country, I would say topmost will be ventilator associated pneumonia. Once you intubate, you are worried about infections. 4 days, 5 days, and next thing you start seeing patches, your CRPs are going up. I think to me, more than BPD, because in the West they talk about BPD because they talk about 23, 24 weeker. For us, relatively bigger, touch wood. So BPD may not be a concern. Infection, infection, and infection. I think I'm sure people who are ventilated It's a major care. The second commonest worry, at least I am worried about, is air leaks. You could have pneumothoraxis, unregulated pressures being given. Nobody knows for that baby how much pressure should I. Nobody knows. Let us be very, very honest. We all take a intelligence when these are there. Okay, you start with 16, 18. Do I really know how much the baby needs? No, I do not know. That's a problem with invasive ventilation, where we are deciding how much pressure to give. We are deciding the inspiratory time. Whatever graphics said and done, at the end of the day, you are still clueless about what exactly needs is what is needed by the baby, or am I doing too much extra? The third thing, obviously, smaller the baby, you are worried about BPD. At least these three major worries are there. And we have always seen that each week of mechanical ventilation should be a significant increase in development. That's what invasive, you are going to the because neurodevelopmental workshop is very much close. You spend too much time on mechanical ventilation, your candidates are going to be in the next work risk for increased neurodevelopmental issues. You should consider meaning at how 9 o'clock or 10 o'clock I have intubated. If somebody asks me when weaning, 10 o'clock, 1 minute, my plan of weaning should start. I mean, you can't wait for, oh, chalo, I have ventilated today and tomorrow I come back. What is the plan? Let us see, he's doing fine. Let me see. Oh, today I'm going. We'll come back and wean on Monday. No. I think the plan of weaning intubated. That's what I said. If you have intubated 10 o'clock, 1 minute, you this intubation, as soon as you intubate, your target should be when can I get the baby out, and not be very happy that, oh, I have intubated, he's saturating 100%, now I'm very happy. No, you're not very happy. Weaning as soon as you intubate. Now, weaning and extubation remain an inexact science is what I've written. What I mean by inexact is nobody knows when, how exactly should we wean. Nobody knows what is the point when I should take the baby out of the ventilator. So there are a lot of when it comes to conventional, the weaning the baby of the conventional exactly to extubate. See, we all know that early extubation is good. We ourselves that do not want the baby to spend more. Bad for the lung, it is bad for the brain, bad for the eyes, bad for the infections, bad for everything, bad for the patient because the cost of care goes drastically, bad for your nurses because the nursing ventilator, because you have 1:1 when the babies are on ventilator. Of cost of work, add to a lot of activity. The only problem with you as a clinician is, okay, I've intubated, I have to extubate. Intubate is comfortable now. But the problem is, how do I decide when do I get the baby off the ventilator? What is that point when I say, yes, he is ready for getting the baby off ventilator? This becomes a bit of a, there are a lot of clinical experience equipment that you should be counting rather than any object parameter to say, okay, now is the point I'm going to get this baby off the ventilator. Sorry, can I go on to the next slide? Hoogtala? Basically, what I'm going to do is across the steps that we going to go with the weaning with bit of an evidence. I'm not going to go too much into the theory. I know this is workshop. So what I'm going to do is go through the steps of how do we decide when to wean and what is the process of when do we extubate the child, how do we check the readiness, and what is the post-extubation care. I think that's the whole cycle of weaning. It starts from the point try to wean, which mode do you wean and when do you extubate and what do you do. Those are the 3 steps I'm going to throughout, and I've kept my slides very, very simple, wanted to make it more practical approach to be, as at the end of the ventilation, practically go back rather than me bombarding you with theoretical
or more of evidence-based guideline as such. Okay, thank you. So the disconnection of ventilator is a complex and a continuous process. Now there are two important statements that are made. It is a continuous. Weaning cannot happen every day morning at 10 o'clock when I come for rounds. The common thing, I come at 10 o'clock, pressures, my PGs are very prompt and sincere till ventilator. They are very sincere. Or at the most, weaning will happen till 5 o'clock, and after 5 o'clock, the charge and don't disturb the baby, don't disturb me also. Reduce the pressures, the baby desaturates, he will have a sleepless night. So the PGs are till next day morning, 7 o'clock, 8 o'clock, the settings will remain the same, and again you come back 8 o'clock, what happened? Just okay when we try to reduce, so we didn't touch. The common thing is the PG comes to invasive ventilation. They just don't want to touch any knobs, including me as a PG. We would damn scared to touch anything because the hell of you do touch something and something else happen. The boss is like, why did you do this? And chodo yaar usko karo. Till next day morning, let him be safe. Is happy, nurses are happy, everyone is happy. कुछ करने जाओ, nurses also say, doctor, you come and keep touching something. वो तब he was maintaining, कर दे आप लोगों ने. So it's a need. Understand us, yes, you can't afford to just come back in the morning and wean 24 hours is modern. This is where I think you need to change your mindset. You need to change your nurses, tell your graduates, it's okay to start weaning gradually as long as they understand what. Yes, make some changes. So they need not be scared and shout, oh, you. So it's okay to allow them, always make it, give 5 to you are empowered to do that. So I think some kind of autonomy should be given to them, but always understand that it cannot be a morning and evening business, it has to be a continuous process. Basic was 3 steps. One is weaning the ventilator settings per se. Second thing is evaluation. So first you come down on the ventilator setting, then you decide is he ready to be extubated, and third thing is yes, once I extubate, what do I do with this baby? This is the complete steps involved in weaning the baby of the conventional ventilator. So weaning of ventilator settings. Now when I say weaning of ventilator settings, so let's get back to any scenario. Let's say you are ventilated a 1 kg 28 week. You went up to 80% to 0.35 of inspiratory time and what else, the flow of around liters and 60 rate. This was the setting he was, and whatever mode you familiar, you MV or to be on SIPPV, whatever the mode you were comfortable with, you chose. Now the plan is, said I have given the surfactant, the baby is doing better now. The process of weaning started at that moment. I have put the baby on mechanical ventilation, I have given surfactant, I have to start weaning that moment itself. It is a given surfactant, I am waiting before weaning. No. So, coming, let's say by the end of evening, you are already on by 16 by 5 and you are about 60 rates. FiO2 fortunately came down to about 40%. So next what? How do I wean him off further? Now you can continue to wean him off on SIMB mode itself. Number one, because that's the commonest mode. At least we were very comfortable with SIMB. We weren't very assist control. Maybe now I do not know if they have changed, but that was the commonest mode we were all comfortable with. So can you wean the concept that I explained to the postgraduate is bring down the parameter that's the scariest. If you are on 100% FiO2, first come down the FiO2 to about 50-60%. You are on 5 or 24 pressure, come down on the pressures first, and then you balance your pressure and FiO2 alternatively sort of or in parallel till you come down to a reasonably low settings, and then you touch the rates. Rates we always touch last in SIMB for 2 reasons. Keeping the rates higher will help you to bring down the pressures because your minute ventilation still remains same. Minute ventilation is a product of tidal volume and respiratory rate, right? So the option is either you keep the tidal volume very high and bring down the rates. That means I can ventilate with 22 by 5 and 30 rates, or I can by 60 rates, the minute ventilation still will be seen. Higher rates are gentler on the lung. One, it helps you to come down on the pressures so that you are getting the baby off the ventilator. Number three, baby is still spontaneously breathing in SIMV, so your fiddling around with the rate will not make a major impact on the blood gas parameters in SIMV because the baby is spontaneously breathing. Let us be very, very clear about it. So don't worry about weaning off the rates in the beginning, the last, and then you start coming down on the rates. Can I wean him off from SIV mode itself? Yes, you can do that. But what is the problem? Let's say now, next 24 hours, I came down to 14/4, right? I came down to about 20-25 rates, my FiO2 dropped down to 25%. Now, this looks to be reasonably okay settings. Now, what is the problem here? The problem, people are little at a rate of 60 and you have now 40 breaths, he's breathe on his own, PWP, 20 FiO2. So what not increasing the work of breathing because he's breathing support breath or assisted breath. You didn't come down on his own breath. He's still breathing 60. Now you have brought it down to 20 breaths and now out of his 60, 40 are unsupported. People are worried maybe this increases the work of breathing. People who are in favor of SIMV say exactly what I want. Him away from complete dependence to complete. What am I trying to do? 30 and 20 to breathe on his own. Maybe yes, it does increase the work of breathing. Weaned him off because I have allowed him to be. People who are in favor of SIMV feel it's to wean him off because giving him that autonomy to breathe. Only thing is maybe because he's breathing through a narrow ET tube, it does increase the work of breathing. But people feel that is what I want. I want to see. Breathe 40 breaths on his own with increased work of breathing. So people who are assist control, his breaths are supported. Problem here is when all his breaths were supported, correct? There is no down to 4 and 25%. Same scenario on assist control. Now my pressures are down to 4/4. My FiO2 is 25%. The rate in SIPP or assist control becomes a backup breath. That means whether I keep it at 30 or 40, it is only acting like a backup breath. It's only if the baby stops breathing, my ventilator rate will matter. Otherwise, it doesn't. All the 60 breaths are supported. My worry is, can I just suddenly take? Suddenly, I'm taking out. I'm saying now, bloody, you breathe on CPAP. Now, not breathe very well. Assist control say no. See, assist. Suddenly take him out from 60 to 0 breaths supported. But no, it's okay. Supporting all is. It is not like only I am giving the breath. Baby was. I was just boosting breaths. He was taking. Not like I was supporting his breath in total. He was breathing on his own. I was only boosting up his pressures. When I was giving 20, maybe I was giving him too much of support. But when he brought it down to 14, I was just giving little bit of. It's okay to wean him off from assist control directly, but at least as long as on ventilator, I didn't increase his work of breathing. I was always supporting his breath. I was initially this much, now, but I'm still supporting him. So it's okay to wean him off from assist control. So I'm just putting it across. As I told you, I am very comfortable weaning off SIME, but people who are using assist control may be very happy from assist control directly to extubate to CPAP. If you want to do that, just understand the pros and cons. Correct? So once you get that clarity, you can always decide what is okay with you to follow in assist control. You understand the limitation of it. That's why in SIMV we don't come down below 20-25 breaths, isn't it? We don't come down to 25, then 20, 15, 5, 0, and then wean him up. Do we do that? No, once we are on 20-25, we wean, because you keep coming down further and further, you're increasing your time on, sort of it works like a ET CPAP, because you're spending more time on ET tube with getting only PWP, which is nothing but like a ET CPAP. Correct? Not much much further, and once you are on 20, 25, and this is assist control you want to do, it's still okay. Physiology. In volume guarantee, what it does is, in assist control and SIMB, I am deciding what is the pressures to be given. In volume guarantee, the tidal volume is about 4 ml or 5 ml per kg. I am telling the ventilator, it's your headache, you decide. So before giving surfactant, the ventilator was delivering 25, 30 pressures. After surfactant, it came down to 18, 16, 14. The ventilator is breaking its head to decide to decrease the pressures that is needed to achieve the set target tidal volume. Let us be very, very clear. So physiological guarantee, because I don't have to worry about it. I just need to decide the PWP. Pressures, whose headache? It's a ventilator headache. Who's trying to turn the knob? The ventilator is doing it by itself. So my PGs can sleep, I can sleep, everybody can sleep, and come back one day, and one day I realize that the machine is not requiring any pressure. Maybe generating that 4 to 5 ml per kg. Said the ventilator, see boss, I have given you autonomy, but you can't go beyond 30. 30 is your limit, or 32 is your limit. You can't go beyond that. I can only set a limit and let the ventilator decide. And next, that the pressure delivered by the ventilator is only 13 or 14. You know that now he is not requiring. Or next day you come back, it's almost like flat. That means the machine is, boss is doing everything, generating 4 per kg. I don't have anything to do. You say, good, now I let the baby take off the ventilator. Physiology will be a best mode. You can start and you can wean them off, because it's a true sense weaning, because the machine will gradually reduce the pressures as and when the baby's lung compliance improves. You have an option to give assist control and weaning, or you want to do volume guarantee. Now people who are on feeling very bad, this 40 breaths are not supported. Pressure support. This is where SIMB plus pressure support comes into. Set breaths, those SIMB breaths, remaining 40 gets only pressure support. Little boost, he decides his own inspiratory and expiratory time. He's just giving a small boost which will help him to support this 40 breaths. Sort of assist control, but not completely supported. In SIMB plus pressure support, you are supporting 20 breaths around 20 rates. Remaining spontaneous breaths are supported by pressure support. That's another mode people have been sort of fond of, but given these options, and you can my wife very well. Go back to you later, you know the knobs, you understand the mode, you understand your ventilator very well. I think you spend a happy married life. That means your babies will be happy on your ventilator. So you might see a lot of fancy ventilator around, but basically what it means is whatever ventilator you are comfortable with, you just give some new ventilator and you don't know half the knobs, you don't know half the alarms. It's very annoying when you go there and some IL peep, low peep, this peep, that peep. Nurses are fed up, you are also fed up. So don't get into that situation. Yes. So what is the problem? Why pressure support is not used as a primary mode? Good weaning mode or pressure support has been very popular for chronic lung diseases. I would say chronically ventilated babies. Let's put it that way. BPD babies. Pressure support is a good mode in that, but it is not good as a primary mode. The reason being, in pressure support, I am only boosting the breaths. I am not deciding the inspiratory time. I am not deciding the expiratory time, only deciding the pressure. But the only problem is, if the patient, we are talking about, let's say 26 to 28 weeker, I am hardly breathing, or I have decided to go into apnea and breathe only once in, 30 to 40 breaths. At the end of the day, the amount of tidal volume that you have achieved of minute ventilator is not decided by you, in-spirit time is not decided by you, expired time is not decided by you, correct? And you are only giving a, so basically assist control without the in-spirit time is pressure support. But if you are giving a full pressure support, like you are giving 18-20 pressures, it is not designed for that. Pressure support is only designed to give you a boost, but leaving the complete autonomy to the baby without knowing whether the baby is going to take adequate breaths, is not going to take adequate breaths, is he going to breathe adequately, not breathe adequately. People feel in pressure support you lose a total control, autonomy. Good mode when the baby's got better, but baby is a 26, 28 weeker, is just born, we don't even know the way he's going to breathe, we don't know how much of, yeah, meaning it's good. Not very sure whether it does a good job, whether we can give pressure support alone, right? What will happen is from switching on to pressure support. It's like a switching off SIMV, completely shifting on to maybe something which you can try. Both, personally speaking, I haven't tried whether you want to switch off of breath. So it is going to be little risky. Good decided to, you know, come and let's say it's a chronic to really worry about. Too much too sure about what is the end product of your tidal volume and minute, but as I said rightly, whether we can only use pressure support, people doing experience, but here the minimum settings we are 14 pressures and about 4 PWP. Can you come down to 3 to 1 PIP, or can I reduce the PIP 14 to 13, 12, 10, 5, or stop at this point? Why do we do that? Why can't I bring down the PWP to 1 and then stop? So there is a physiological PEEP. The physiological PEEP is 3. So when I'm on ventilator, remember whatever you are set on ventilator, that's the physiological PEEP. So you can't come down below 3. So the minimum is 3. So you have to keep, because it's a disease, you don't want, you know, plant lung like or a post, put down to 3 below. Even if it's a small baby. So 14 by 4, rates of, as I told you, 20, 25 more. Reason why you try to on control, you don't talk about percent. Same thing happens with in what it is a tidal volume. People say the minimum tidal volume you don't come down to is 4 ml per kg. Don't come down below that, because you are trying to come below that, then you are actually increasing the work of breathing. Then the patient is trying to do too much of it. So it is what you have to put on, and you can not less than. This is a reasonable. What is the minimum setting when you say ventilation? What should be the ABG values? Remember again, I Dr. Sharma highlight workshop is we move away. We are not interested in getting normal. That is not my target is to see how best I can get the baby off to accept the blood gases which are slightly abnormal. That means I am okay with the permissive hypercapnia of 55. I am okay with the PaO2 of around 50. I do not want a normal blood gas, because if I am in a process of normalizing the blood gas, I will spend more time on ventilator. I delay my extubation. It's okay. PaCO2 pH is more than 7.2 to 7.25. Go ahead, no issues. Don't increase the pressures, because you don't want the ABG to come back to normal. You have over pH, not to normalize the blood gas. The target, get the baby out of the sickness, get the baby out of the ventilator, and this will only happen if you start accepting a slightly normal. If I 35 to 40, no, I'm coming down the pressures. Again, it went. And permissible hypoxia is a norm, because you want the baby to come. Do not want to spend time trying to normalize, which is not our aim at all. Our aim is not to normalize blood gas. My aim is to out of the crisis, get the baby out of the ventilator as early as possible should be my target, and you norm not target. Not normalize your settings. You can chase the blood gas 48 to 72 hours. You're done. Please accept little higher PaO2 and higher PaCO2s and lower PaO2 and try to get them out. I think these are the major key messages that should get in today. That if I am weaned, I need to be blood gases and not have a normal blood gas as such.
Lot of applications to his credit also.
Okay. So the next question is, now I have
Hospital.
something like 1 kg
He
came
has,
down, and
rich
I
experience
say
with
unit I would have been IMV or 14. Point is, how do I know this baby is ready for extubation? Is it pull out the tube really comfortably? So what is the concern when you are extubating the child? My worry is, will this baby be able to continuously breathe? Will he go into apnea? Will he have some collapse? Will he require a reintubation? So sometimes अच्छा चलो यार ठीक है निकालो वेंटिलेटर देखेंगे नहीं मेंटेन कर रहा है तो डाल देंगे ठीक है. And the common is the what is the question you ask yourself? करना है या नहीं करना है, right? Is ABGs are acceptable? Easy breathing, spondy, SIMV breaths we are only supporting. What other question do you ask yourself? At least I. हाँ पहले कि आज ड्यूटी छोड़ो यार आज नहीं सुबह के एक्सटूबेट करते आज एक्सटूबेट मत. Lot of the ventilation. Yes. The traumatic. And mortality to the baby. You are at so experience right. Basically what I see for, I saw whether he was pink, he was enematic stable. I looked at his settings, I looked at blood gas, I looked at reasonably efforts. I feel ki chalo can be, but how sure I am, yet with experience maybe your prediction might go up, but ventilator has happened because way clinically, though clinical prediction still holds good, but still there is a lacuna or clinical assessment. So people objectively know this baby is ready for intubation. About what it is not a standard of care. Let us be very, very clear about it. It's not a standard of care. Limitation. What is that you are doing in spontaneous breath test? Not nothing new. This is what you would have seen in PICU or in adult when you are interns or TP. ET CPAP. Now TPs they call it. No, they don't call it as ET CPAP. Basically, what is TPs? It's nothing but a CPAP. So what they do when they extubate the child, they put on TPs, which is nothing but continuous ET, and they say ki, they wait for his own effort to get him out. So TPs is nothing but ET CPAP. What they were doing is, so people have tried to can I put this newborn on CPAP? As a postgraduate, we CPAP for next 20 back and put on ventilator breathing. It's like breathing through a straw. You put in a straw and you tell him to take breath. You're breathing. It does increase the work of breathing. The narrower the radius, more the we are doing in 5 minutes. You change the knob to ET CPAP. Keep a a CPAP of around 5 centimeters. What do you look for? Two things. One, you look for an episode of bradycardia, which defines as seconds. Drop in even if you have increased the FiO2 by another 10-15%. A saturation of less than 85%. Past him on his own or not, able to maintain his own minute ventilation or not. If he is not able to maintain his efforts, poor for what reason he was not able to breathe, obviously saturation will drop. That's a simple test. It's not very common sense test that. There was a system. There was still a group of babies who failed extubation even after passing spontaneous breath test. That means it could not predict all. The specificity is, sensitivity is good. That means you still cannot predict all the babies who are going to fail. But you can sort of say his past SBT is a good chances of getting him off. But just because he passes, does it guarantee that he will have extubation failure or not? He is still no guarantee, can still have. So it's still not a best test, but you could try this in case you have a doubt. I am not too sure should I extubate him or not. Put on spontaneous breath test, see for 5 variability. People have tried to see tidal volume variability. People have tried to look at heart rate variability, respiratory variability, minute. Like in say NST, variability is norm. We breathe at 20 breaths. I cannot constantly make heart at 70. Something is wrong. I have to have variability. So people have variability of various parameters, and for too much of his it boils down to a simple message. Still all in a sort of experimental thing. None of them are very thing, and they need a very sophisticated tech what you call ventilators to measure all that. So as these parameters are, you can do is clinical acumen plus your spontaneous combination. Next slide. So am I clear about this extubation? Just giving you a key messages. I'm not going into the details, but I'm just giving very practical take home messages. So please, as long as you take that messages, it's good enough. Next, we'll talk about what to do with these babies once we are the need for mechanical ventilation, long-term benefit. BPD, so you want to give Kepin to all babies who are less than 29 weeks. There is no about it. How one people at least by 72 hours. That means at least 24 hours prior to extubation. I think more or less it has become a norm in most of the units. I don't think I'm about. Next, what do we do with post extubation? Should I? I'll just tell you the logic is maintained when ventilator. Now, when suddenly I take them off the second is they can have obstructive apneas. Third, they can have poor efforts and they're going to have a central apnea. That is your concern. That either you may have apnea or you may have a collapse because the FRC is suddenly lost. What can I do? Putting on some kind of a non-invasive support. Till you feel the baby is breathing very well, and then you gradually wean him off is a better way to do. And suddenly I was doing everything and suddenly I take out, chalo, now it's your life, enjoy. No, he's still going to need some kind of a support, and the best support is in the non-invasive. What more options do I have? CPAP, good physiologically because you are keeping the upper airway open, keeping his FRC very well, better diaphragmatic movements, right? And some amount of oxygenation. Fantastic. My nurses are not very happy. I can't do KMC. The mother has already waited for 3-4 days to KMC. I want to be in the next room, good developmental to take care. HFNC has post-weaning has found to be as effective as CPAP. As a primary mode, HFNC or HHFNC has found to be as effective as CPAP. So you have a choice. HFNC is easier to operate, looks much simpler. Nurses love because the mother can handle it. Nurses love because it's cumbersome tubes being fixed. Can it work as effective? Evidence says yes, and my experience also. It still has a residual lung. Your lungs require a good amount of. This is something which people have tried. Ki baby, you put on CPAP, he's still having apneas. Instead of reintubation, can I put on NIMV? Understand, NIMV that we are going to give is not synchronized. It is not SNP. It is not synchronized nasal intermittent. Most of the trials were done with. There's an abdominal capsule. So nowadays they have NIMVs which can synchronize with the baby's. You are high pressure. You are worried about those pressure jet being directed. Maybe better mode in CPAP. People are If your babies are on CPAP, do not want to intubate, can I try this NIMB? You can try, but use a ventilator which can synchronize would be a better thing rather, because we have had not very good experiences. See, once you put on NIMB, there is no IMB. Whatever mode you're going to put, it is. So basically, once you put on you cannot synchronize unless until you have an option to synchronize. So basically, what you're doing is nasal IMB. Whether you're putting on SIMB or you're putting on CMB or IMB, it is basically IMB. So that's what they say, but you are not synchronizing. So basically, it becomes IMB. It's like SIMB mode पे आपका flow sensor काम नहीं कर रहा है, तो it is actually IMB. Your mode says SIMB, flow sensor is not working, it is IMB. Practically, it is not synchronizing at all. Same thing here. Once I put on NIMB, though it says SIMB, unless until I have an option of abdominal capsule or my ventilator is able to predict the breaths and give synchronization. So virtually whatever mode you're going to set, but it is going to work like IMB only. So I'm not giving any standard recommendation. I'm just telling you pros and cons of each mode for you to understand and you choose what works best for you. First, there is a common problem. Do we use routine steroids? No routine steroids. Can I use steroids in some situations? Which situation can I think about a small peri-extubation, low dose Dexona? When I say low dose, it should be less than 0.2 mg. Is you had a he had tried 2-3 times and he says, "No, sir, I had patient failure. The strider, you had intubated. There is a lot of subglottic. You can use the short pre-extubational Dexona. The dose is less than kg. Low dose Dexona for strider can be tried in selected babies. No routine peri-extubation steroids. Let us be very, very clear about it. People have tried adrenaline as compared to use the subglottic of evidence-based practice. So what is very, very important is that post-extubation care is as important as extubating the. So I almost come to the end of my talk. Any doubt? Make very sound physiological. I have not tried to go abroad and bombard you with some recommendations, but identify whatever move, because ventilation is very much your उसी को अच्छे से संभालो, your life will be much better than saying कि नहीं यार मैं नया बीवी लेगा, because again you're going to have some new problems. So buy new ventilators, you're going to have new problems. Stay with your old ventilators, you're much better off. Right, cool. So I'm coming to that key messages. So what it make it a process of weaning should start as soon as baby is ventilated. That is the first message I want all of you to go back. When should somebody ask you when should you start weaning? My weaning will start the next minute I start. I have intubated the baby. Well defined unit protocol. To do this. Guidelines and explain to you pros and cons so that you can go back and decide कि क्या करना है. You want a clear-cut protocol. You want to do spontaneous breath test. Yes, you want them to be documented. Do you want a pre-extubation blood gas? Do you want an X-ray? You decide कि क्या करना है. You decide how it is to be done. Put it in writing. Train all your nurses, postgraduate. something else. So then the chances are you might have in the unit. Weaning of infants from mechanical ventilation much as art as science. That's what I was trying to tell you. A lot of clinical decisions, that are of pros and cons with each mode or each thing that you do, but as long as you understand, that's precisely why I always tell in ventilation, teaching you ventilation is teaching you understand the ventilation, understand the process. SIMB, mode phase, ventilator phase, doesn't matter. As long as you understand what is SIMB, what is assist control, what is pressure support. You understand that, you understand the limitation of each, then you know to play around with any mode. Nobody has said that one mode is better, other mode is better. Nobody has said. Only thing people have said is volume guarantee is better than patient triggered because it has a natural weaning, and definitely it has shown to be evidence based. But problems in volume guarantee also, which I think I'm going to talk 2 days later on the volume. I hope I'm being very easy, but if there's anything that you still want to clarify or discuss, to discuss rather, because I'm sure all of you have ventilated, all of you have done something. So if you felt something was done better or different than what we have discussed for benefit of others, you can share your experience or anything that you want to add, or anything that you could not understand or clarify, or you felt the explanation. Yes. So we have a short break for the coffee. We'll be a short break so that we can go back a little earlier. We have more of work because there
Okay, so I think we'll start with the next session. Okay, now, like I mean, what my professor used to say is, ventilation is like an aircraft journey. So you safely take off. Then Dr. Pradeep has safely landed the vehicle. Then we had some arrows to give us some coffee. Now suddenly we run into a cloud or somewhere, a bumpy ride. So suddenly we have some issues on the way. How are we going to handle that? That Dr. Sridhar would be dealing. He is a consultant neonatologist at Rainbow Children's at Hebbal, Bangalore. Okay, thanks a lot. Welcome.
Thank you, sir. Hi, good afternoon, everyone. So my job has been made both easy and difficult by the ones who spoke to me earlier. Most of the things have been covered and in detail, especially they focused a lot on basics of understanding ventilation and graphics and stuff. So with that, I think my talk is going to be easy and easy for you guys to follow also. It's also difficult because most of them are stalwarts and they have raised the bar. So I would keep, it will be a brief presentation. I assure you, I know lunch is due in the next 1 hour, and we'll try to keep it as interactive as possible. I would be speaking briefly about sudden deterioration of a baby on ventilator and also about VAP prevention bundles. Would begin with sudden deterioration. So this is a nightmare, but it's inevitable. So when you are, I mean, most of you can relate, when you are a resident or registrar on duty, there is a baby on ventilator in the NICU. What do you want is not to have an eventful night, isn't it? You don't want the baby to deteriorate. That's what you want to tell the next person who comes to relieve you. It was fine. Everything was fine. But then things don't go as planned. It's inevitable that these things happen. These are not uncommon events. Many troubleshooters such not. And I'm sure you're all already familiar. Many of the things that are taught about deterioration. This is one of the NICU, isn't it? What will you do if a baby deteriorates? So dope, I'm sure you already know. So what I would do is a brief case-based scenarios. We'll try to keep it a bit and then try to give a structured approach to it. So next time when you encounter a situation like that, it will be easier for you. So this is the acronym that all of you are very well aware of, DOPE. It simply is a list of the conditions which are the most common conditions which are the reasons for a baby on ventilator going in for a sudden deterioration. D stands for displacement of the endotracheal tube, O for obstruction, P for pneumothorax, and then the equipment failure. What I would focus on would be this. So whenever there is an event, how are we going to approach it? So it should begin with history taking. This is something that most of us don't realize is important, especially when a baby is deteriorating, is bradycardic, is near arrest situation. Have time to ask history. We just jump into conclusions. But let us see why it is important and how it can be useful. Examination of the baby. How often do you do it? A baby on ventilator rate of 50, saturations at 20, 30. What is the next thing you do? What is that you have done till now? Examine the baby. Why is it important? We'll see. Examination of the equipment. So only thing we see is that big alarm, the lights which are lighted up on the ventilator, and then jump into intubation, or we jump into say disconnect and let's bag. So we'll see why it is important to the alarms. The ventilators are designed to solve this problem. So the ventilators especially have a lot of technology, and most of the time already there in the alarms that they give and the kind of graphics that are being displayed. And then we will run through some of the brief clinical to bedside on an emergency basis. We do the diagnosis and find and try to save the baby. So I'll begin with the case scenario. It's a 25-week baby on ventilator. You just walked into the NICU and the baby starts deteriorating. Not uncommon, isn't it? The nurse would say absolutely fine, and then only when you walk in the saturation is 50, heart rate is dropping. So how would you manage this baby? How will you approach? I know there are very few people here, but if you can raise a few points, basically from your experience of how you have managed a similar scenario. So what would you next? Change. Okay, check for air entry, she says. Excellent. Excellent. He wants to check for hypoglycemia, hypothermia. Okay. Anything else? Good. We are on track. Okay. So she wants to see if the tidal volume is being delivered or not on the ventilator. Excuse me. Change, please. We need to check for dope. Okay. Good. So how are we going to do it? Examining the baby. Good. So we are on track. Thing you should. So we have been running into a lot of problems, isn't it, with the audiovisual. Next. Okay, so the thing I would probably the only two lines I told was 25-week are on ventilator and the baby deteriorates. The scenarios can be multiple, and more information would definitely help us resolve the issue in a better way. third slide. Enough. Next. Seek more information about this baby. Besides, of course, we don't have a lot of time, but within that brief few seconds, minute that you get, we have to have as much information as possible. Always better to go methodical and speak to the person who has the baby and ask what actually happened. Most of the time, this itself would solve the issue. Briefly examine and see what the ventilator is saying, and then tests or not. So when you actually to the nurses, which you many times don't do, or the junior person who is standing there, or your colleague who was there. So when you actually speak to them, the nurse actually tells that there was an alarm for the humidifier, and then she had refilled it, hopefully with a sterile fluid. And after that, when she restarted ventilation, the baby went suddenly cyanotic and limp. Okay. So does this tell you anything? Yes. Excellent. So probably that, but then there are many other things. You see, when we say dope, everybody talks about most study material that you get on sudden deterioration will start with dope and end with dope. But then nowhere it's given where you should start or where you should end. It is not that you should always look for placement in the beginning or equipment failure in the end. So you should quickly decide which is the one that you are going to prioritize, and that should be based on the information you have. So, I mean, leak just proximal to the endotracheal tube. And now we'll look at the ventilator. So in the ventilator, you have to see two things. One is the alarms that the ventilator is giving. Second is the kind of graphics that are being displayed. So the alarm says that there is inadequate tidal volume / minute ventilation and there is apnea. This is something that most of the ventilators will be able to tell you. And you look at the waveforms, there is no rise in pressure, flow or volume. Remember the waveforms that were shown to you when you look at the scalar, the pressure has to rise over time. So is the flow and the volume. None of these things are happening. So what does it mean? What are the possible things here? So what are the first thing? Tell that the baby is not being ventilated. And the same thing is shown on the ventilator. So what could be the reason? The reason could be either that the ventilator is not delivering any breath at all, or the ventilator is delivering breath which are not reaching the baby. Okay. So the two possible things. One is a significant leak prior to the endotracheal tube. So please remember, only if the leak happens after the flow sensor is connected, that is distal to the place where we connect the flow sensor, that leak will be shown in the ventilator. But if the leak is happening before that, then the flow sensor will not detect any flow at all. So basically, how does the ventilator detect a leak? It detects a leak by looking at the difference between inspiratory flow and the expiratory flow. If the amount of gas that is flowing during inspiration is same as that during expiration, that means there is no leak. When that is not there, it says that there is a leak. But here what is happening? Probably there is a leak proximal to where you have connected the flow sensor. In which case there is no flow both during inspiration and expiration. And your ventilator will not show that there is a leak because the leak is proximal to that. So the possibilities include that probably there is a leak proximal to the ET tube or inadequate flows. So these inadequate flows we rarely encounter in the present day, in most of the ventilators at least, because we don't set the flows are set by the ventilator. But even Drager has a knob where we have to actually set the inspiratory flow. If accidentally the inspiratory flow has been turned very low, then also you'll encounter the same things. So the history said that probably someone meddled with the circuit near the humidifier, and then the alarms and the graphics are all suggestive of a leak proximal to the endotracheal tube. So what we have to do is run your hand all along the circuit from the place where it's connected to the baby till the place where it's connected to the ventilator, see where the leak is and rectify it. So one of the most common sites of leak is where the tubes are connected to the humidifier. And also there is a knob where you open and put the fluid. So if it is not completely locked, then you will see this kind of a situation. Okay. So coming to the next scenario, this is a term baby who had asphyxia, hence was intubated in the delivery room, is transported to the NICU. Connecting to ventilator in the NICU, there is deterioration. This is again not an uncommon scenario. Many of you would have experienced it, whether it's an inborn baby or an outborn baby. The moment you take the baby into the NICU, trying to ventilate in the baby is deteriorating or not improving. So what do you think? How will you approach this? So again, we should go through the same cycle. So ask what happened. So this baby received 4 cycles of positive pressure ventilation at birth and then was transported using an umbu bag to the NICU. So what all can go wrong here? Pneumothorax, because we have given positive pressure ventilation at the time of birth, and also the baby was transported using an umbu bag where you cannot always regulate the amount of peak inspiratory pressure that you are giving. Okay, what else? Tube displacements because of transport, and also it was intubated in the labor room, so we don't know how well it was secured. Excellent. Then yes, secretions less common within few minutes or in the initial few hours, but a valid point. Thick secretions blocking the ET tube. What else? Inadequate ventilator support. So we need to look at what is happening in the ventilator. What are the set parameters? Are they right? And whether the same things are being delivered or not. So another common mistake you do is in most of the ventilators you have 2 screens, the set parameters and the deliver parameters. So when we say see what is happening, the set pressure is 20. That doesn't mean the same thing is delivered to the baby. So go to the screen where the measured parameters, the parameters that are delivered to the baby are being displayed. Okay. So this baby on examination, so this history, so these are all the possible things. Of course, the entire spectrum of dope is still possible, from ET leak, displacement to all those things to equipment failure, circuit leaks, all these things. But probably one of these things is most likely to be the cause. You examine the baby is limp, cyanotic, has poor chest rise. Auscultation is one thing that we often don't do whenever there is such an acute iteration. So I encourage all of you not to miss that very vital step. Breath sounds are louder on the right side than the left side. So with this, can you narrow down your differential diagnosis? Yes, pneumothorax and tube displacement. So if the tube is too in, it is ventilating only the right lung. This can happen. Where the left lung has completely collapsed, you are essentially ventilating only one of the lungs and there is inadequate ventilation. Or if there is pneumo, there is a substrate for development of pneumo because of positive pressure ventilation and transport on umbu. Okay. So what will you do next? So we have history, we have examined the baby. Next is what? Look at the ventilator. So the ventilator says that the peak inspiratory pressure is reached, but the tidal volume is low. What does it tell? Does it mean the ventilator is at fault? Does it mean? Probably no, because what we do on ventilator, most of the times we do pressure control ventilation. So the ventilator is generating enough pressure, but these pressures are not sufficient to generate the necessary tidal volume. So what does it mean? So what are the possible causes for this? Yes, excellent. So the lungs are very stiff. If the lungs are compliant, then you generate a pressure, they always get distended. They are not compliant here. So why should the lungs on a term baby be not compliant? Again, pneumothorax or single lung ventilation, where your tube is completely in the right lung. So these two are possibilities. Very rarely, again, pulmonary hemorrhage, congenital pneumonias, all these things are a possibility, but the most common ones are these. Okay. And you look at the graphics, again the same thing, tidal volume is not reached, and always look into the loop where you see that the loop is displaced to the left side and see what is the compliance. So most of the ventilators also tell you what is the compliance. So how they calculate what is the pressure that is being generated and how much is the volume change that has happened. So based on this, the ventilators will be able to give you the compliance also. So poor compliance. So what do you think we should do now? Okay. So what do you think we should do? So one of the things that we can do is we can do a cold light test. Okay, so where you darken the surroundings put a small torch, it should have a small footprint. You cannot have a torch with 10 centimeter, with covering the entire chest. That cannot happen. So you put it and see how is the transillumination. So here it's one of the cases where transillumination test was positive. Okay. So the diagnosis is pneumothorax. And what do? Drain this. Okay. And we all know how that can be done. The other possibility, any other tests can we do? Bedside, yes, bedside ultrasound. Somehow the picture is not displayed. Okay. So bedside ultrasound is an effective tool. It's easily available, and you have the reports even before your X-ray, isn't it? X-ray, at least someone has to go down and take a printout and come. Whereas for the ultrasound, you see it in real time, and literally within seconds, you can know what is happening. It's standardized to some extent, but somehow the routine use in clinical practice has to increase. It is not something that is easily adapted into clinical practice now widely, but the centers who have been doing it found it to be very useful. So you look at one of the recent systematic reviews which compares chest X-rays with ultrasound. Ultrasound is as sensitive and as specific as chest X-rays. In some of the trials, it was even better in detecting small pneumothoraces, which of course are not clinically significant. And also, the time from clinical suspicion to diagnosis and intervention was significantly less when a bedside ultrasound was used. Okay, so this is something that you can learn. It's more of an art. You go on doing, there are subtle signs of pneumothorax, like you see a lung point and absent sliding sign. So it's another thing that you can potentially use for a baby who is deteriorating fast. So you drain the pneumothorax, that is the intervention. Another common finding could be something like this. So what has happened here? The tube is deep into the right main bronchus and the left lung has completely collapsed, and you wonder what is happening. So what had happened was that you inserted the tube deep into the lungs. So one critical thing that you must all check in a baby who is deteriorating is, where is the ET tube fixed? And often there is so many rounds of plaster around, you may find it a little difficult. So you should have a standardized practice of fixing the ET tubes properly and know where exactly it is. So the marking just on the outer lip, okay, that is the mark which signifies the length of the ET tube. There are several practices to prevent this. Okay, so how do you guys know what length of ET tube to be fixed? So one of the most reliable and easily practicable thing is to do measure the distance between the trachea and the nasal septum, add one to it and then fix it. But then it should always be confirmed with a auscultation to look at equal air entry. And before you ventilate or immediately after you ventilate, you are taking an X-ray to confirm the position of the ET tube. Again, different techniques have been used. People have used ultrasound to know where the endotracheal length, whether it is appropriate or not. And these are also, there are many research articles, but not widely practiced clinically. Again, it's as good as chest X-ray. If you take chest X-ray as the gold standard, by ultrasound also, by knowing the right pulmonary artery and measuring the distance between the tip of the endotracheal tube and the pulmonary artery, we can actually know if the ET tube is inserted to the proper depth or not. Okay. So you have a similar scenario, term baby who went through all this, except that when you examine, the baby is limp cyanotic, has poor chest rise, and auscultation, breath sounds are diminished on both sides. So now what are the things that you would think? Excellent. Endotracheal tube can be blocked or inadequate ventilation. That means the ventilator is not delivering the set pressures, hence the set volumes are not being generated. It can be because you have inadvertently or inappropriately set the parameters on the ventilator wrong, or there is an equipment failure. So what we should do is, we should examine the ventilator graphics. Okay. So the alarms say that the pressures generated are low, and also the tidal volume is low, and of course in the scalar loops also you see that the desired pressures and volumes are not being generated. So what are the other possible things here? Yes? Yes. So one of the things is displacement of the tube or inadvertent intubation into the esophagus. Okay. So here that's actually a picture of the pressure volume loop. So you know how to identify a leak, isn't it? It was shown. So in the flow scalar, you will see that the expiratory flow is absent. Only there is inspiratory flow. That means the air is passing across the flow sensor during inspiration. But during expiration, it's not coming back through the ET tube because the endotracheal tube is displaced. And the same you would see in the a loop where the expiratory limb terminates much before the place where it started. So there is a leak there, and here we go and re-intubate the baby. Okay. So endotracheal displacement is also very important thing. So you have another baby, 30 weeker, stayed in another NICU for a week, then shifted to you because they are unable to extubate. So next day, the baby deteriorates, and this is the history. So a lot of secretions, and the previous was suggestive of VAP, but then we are not convinced. So there was a similar episode an hour ago, and the sister did an endotracheal suction, the baby improved. But this time the baby is not improving. So what are all the things you will think? What is the most likely cause here? So most likely cause is probably an ET tube block, because there is a substrate for that, probable VAP, increased secretions which are thick. Okay. So on examination, here the baby is struggling, he is cyanotic, has good respiratory efforts, but there are retractions. So what does it tell? That means that clear-cut airway block, the resistance to flow is more. That is why, in spite of the baby trying to generate pressures and volume, that are not being generated. So here we almost know that it is ET tube block. And the device would show what would the alarm? Low tidal volume. What do you think would happen to the pressures? The pressures would be reached, but the volume will not be reached because the resistance in the tube is more. Given enough time, the volumes would reach, but then we are not really allowing so much time for the baby. So there's a huge pressure gradient between the ventilator and the baby. So pressures would be reached, but not the volume. And there are no leaks. So this is most likely an ET tube block. So you can suction, and if it's not improving, probably you will have to extubate and re-intubate. So again, one thing here, routine suctioning is not recommended. It is not going to prevent a catastrophe like this. Suction only when necessary. And there is not much of difference between closed loop suctioning and open suction devices. But in some situations, probably closed loop suctions fare well in terms of preventing infections and preventing de-recruitment of the lung. And adding saline to the endotracheal tube before you suction, please don't do it. It washes away the surfactant and you're introducing infections. Proper chest physiotherapy, positioning the baby and suctioning when necessary would prevent this. And we have discussed how to identify and cure it. So essentially I covered most of the dope things. But these are not the only causes for a baby who is deteriorating. I am sure you all have encountered a situation where all these things were not there. So what are the other causes? If a baby is seizing, is having posturing, then what is essentially happening there is the chest is constricted, restricted, the compliance is very high and the tidal volumes are not reached. In a baby who is encephalopathic, who is sedated, it's not easy to identify a seizure episode. But if the baby is already paralyzed, remember this, that means the muscles are not contracting at all, then seizures are unlikely to be the cause of this. You understand? A baby who is hypotonic because of severe encephalopathy, or you have relaxed using a muscle relaxant, don't think of seizure as a cause for deterioration. Seizures can cause some amount of autonomic disturbance, desaturations, bradycardia, tachycardia episodes, but not a catastrophic event where the air entry is not there, tidal volume is not delivered, pressure is not being reached. In such a scenario, seizures are not the cause. Seizures are a cause where the muscles can contract. Baby is vigorous, is not severely encephalopathic, so has an episode of seizure, especially tonic spasms or posturings. For example, a baby with intracranial bleeds, there that can be the cause. PPHN crisis, we all know this, especially the term or the near term ones, the big babies who are meconium aspiration syndromes, who are ventilated, you are trying to sedate and paralyze. Sometimes worsening can be because of pulmonary hypertension. So they behave the same way because not enough blood is reaching the lungs. You're ventilating the lungs well, fine. Your pressures and tidal volumes are reached, but the baby continues to desaturate, ends up having bradycardia because the blood is not reaching the lungs, and no matter how good the ventilation is, ultimately the systems are not getting gas exchange. Okay, so here, after ruling out dope, after looking at the pulmonary graphics, make sure the ventilation is good, and the next thing probably you should consider should be P-patient crisis. Cardiac tamponade, again, cardiac perfusion. So we had a case recently, baby on TPN deteriorating, there is lot of pericardial effusion, and it is not always dope. And X-ray, remember, is deceptive in cardiac tamponade. Cardiomegaly will not be that much because the pericardium is limiting the cardiac size from increasing. So fluid is accumulating, the heart size decreases. So do a quick echo. You need not be a master. All you have to do is look at the four-chamber, direct posteriorly and see how much fluid. Go to Paris long axis view, you see that the right ventricle is collapsing because the pressure is so high outside. Okay, so no matter how many cycles of dope you do, how many cycles of X-rays you take, unless you diagnose cardiac tamponade and treat, it will be difficult. Same with arrhythmias, whether it is a heart block, severe heart block, bradycardia episode, or an SVT myocarditis ultimately failing. So all these things should also be borne in mind. Okay. So to summarize, I was not trying to teach you something extraordinary or something very new. I was trying to just give you a structured approach to an uncommon, I mean not an uncommon thing, a common thing that happens in an issue that we all have to face. So I would say do not react. As soon as a baby is peri-arrest situation, don't go and do everything. Someone disconnects the baby from ventilator before looking at the graphics, tries to re-intubate without achieving proper ventilation. The problem could simply be a leak in the circuit, and all you have to do is correct that and probably increase the FiO2 a little. So don't just react, try to analyze and respond. Always follow a structured approach. Consider the common causes. If you diagnose uncommon causes, if you diagnose rare causes, you're rarely correct. If you diagnose common causes, you're commonly correct. Okay. And sometimes when your dope is not working, think beyond dope. Sometimes a fresh perspective helps. So it is a team job. Not one person cannot do it. So we had a situation where the baby was not improving at all. You umbu, baby improves, connect to ventilator, baby is not breathing. What had happened was the flow was turned to 0 and we didn't realize. And it is not a common thing that we frequently said. Okay. So sometimes a new person walks in and say, hey, the flow is very less for this baby. Okay. So work as a team and we will be able to save most of these babies. So next is ventilator associated pneumonia. So you don't extubate early, this happens. Okay. So I'll go through some of the structured things about VAP also. I'm sure most units have VAP bundles which are aimed at preventing this. So as I was saying, your plan to extubation should start the minute you intubate. You should have a clear-cut plan and when are you going to prevent this. There are a lot of VAP bundles, but you know what is the best way to prevent VAP? Not to ventilate or to extubate them as soon as possible. So non-invasive ventilation has taken a big way. Many of these babies are being now managed on CPAP, to some extent on NIPPV also. So try not to intubate. If you intubate, try to extubate as soon as possible. So this is probably more of academic importance. The definition of ventilator associated pneumonia is given by the CDC, the National Healthcare Safety Network. Basically, they concentrated more on the radiological features where there is a new and persistent radiological feature. New means, see, most of us do take an X-ray at the time of intubation. So lungs parenchyma are normal. Then you repeat an X-ray only when it is indicated, when probably there is poor oxygenation. You find new shadows. That persistent radiographic infiltrates has not been defined. That means how long should they be persistent to call them as persistent? But then probably not transient, something like a collapse which disappears by next day, that probably will not take it as VAP. It persists beyond a day or two. Then most of these VAP definitions indicate that the baby be ventilated for at least 48 hours. So whenever there is a infection of many things, to ascribe it to the process of ventilation itself, the baby should be ventilated for at least 40. So these things and at least 3 of those criteria for your systemic inflammatory response. That means the underlying infection has affected the system with temperature instability, tachycardia, bradycardia, your leukocyte abnormality, change in respiratory secretion. that the nurses frequently tell. Probably they pick up VAP much of us, even before the FAO2 goes up. They say from morning we should pay attention to that. Respiratory distress because of impaired compliance and poor gas exchange. So these are a few technical terms that most of students at least must be aware of. Basically, this was done to improve the reporting and surveillance of VAP. So now these are the terminologies that are used. All these things are classified under a broad term called ventilator associated event. And there are 3 tiers to it. The first one is a ventilator associated condition, which simply means gas exchange in a baby who has been ventilated for at least 48 hours. Now the causes for this can be many. Can be pulmonary interstitial emphysema. It can be VAP also. But all these things come under the umbrella term ventilator associated condition. We call it as IVAC, that is infection related ventilator associated complication. If there is poor gas exchange, which is objective evidence of pulmonary parenchymal inflammation, and the second criteria actually reflects this. So when for at least 4 days, that means we have thought that that event was due to a significant infection. So if often we stop antibiotics at 36 hours or 48 hours. So we cannot take that event as an IVAC. But the very fact decided to continue antibiotics beyond 3 days, that means that event was probably infectious in origin. And that marks the definition of IVAC. Possible or probable VAP mandates the demonstration of inflammation lung parenchyma by looking at the white in the ET tube secretions. So all these definitions do not because we process of taking secretion culture is a mandatory. More of a clinical diagnosis, a gut feeling and investigations. There's an interesting slide, a US study. X-axis is the gestational age, Y-axis is the incidence of VAP. First one is actually 22 weeks and 23, 24 and 25 weeks. You can see that most of the cases are VAP between 25 to 27 weeks. 22 weekers have less incidence, but they are actually having lesser incidence. It's because their survival is probably less. So it does not mean this extreme preterms 21, 22 weekers don't have VAP. Okay. So most of the VAP from the US are, it basically reflects the amount of invasive ventilation. A 27, 28 weeker baby will not go on invasive ventilation nowadays. They're mad. They go home. So the incidence is less on 28 weeks. This is the US, which said the incidence is about 0.8 to 1 per 1,000 in ventilation days. But many of the developing countries data is 35 to 40. And there are some studies, if you look, where the incidence is much more higher. Okay. Another slide, somehow the picture is not displayed. Fortunate, more slides. Shall we? We'll just continue. I don't think they are going. Ready. Okay. So this is a patho. So probably in a few minutes, how VAP. I wish the picture. The organisms can gain entry into the lungs. It is exogenous, where from the surroundings it is reaching. The second is endogenous. It's important to know this because all the strategies at preventing VAP basically are derived from these pathogenesis mechanisms. So external means the organisms must gain entry through the ET tube. So the most common places of entry are through the ventilator circuits. So it's a common practice that many people just sterilize and reuse ventilator circuits. So if they're not stored properly, or if the sterilization of the equipment is not done properly, it can cause that. Humidification is the another very important source. We have to make sure that sterile water is put in the humidifier and not non-sterile water. And the process of putting water into the humidifier is also important. You would have seen nurses puncturing the bottle many times, which often keeps leaking. The preferred route is to have a closed system. So most of these humidifiers have a automatic system where it fills when the water level comes down, and then it closes on its own. So we should. The most common organisms are from the healthcare worker's hand. So hand hygiene is of supreme importance. The other organism is by colonization of the tube in forms. Ultimately, organisms migrate to the lung that has been one study where they looked at the presence of peptide, which is a marker of gastric secretions in the pituitary secretions. That are there get so you will see how that is reflected, how we prevent VAP. These are some of the common organisms: Pseudomonas, Staph aureus, Klebsiella. That will cover 90%. Common to see organisms also. There is one concept of doing quantitative cultures, but then that is not evidence-based approach, and most of the recommendations recommend for using quantitative cultures of the ET secretion. Are extremely important. I'm sure you for all patients. Systematic review? No. For most of these evidences are based on biological general accept. This slide for VAP is so very important. Are from evidence from the adult studies, and there are 4 in neonates. Agriculture professor. Personnel which are involved in care of this ventilator baby. Hand hygiene is the most inexpensive tool. Elevation that it decreases. It is 30 proper positioning of the tube. Comes this lateral position helps prevent VAP bundles. At least one trial which said in prevent, the best way to prevent is not to ventilate, extubate as soon as possible. Day. This baby on ventilator and long. not for that, and it is potentially for increase.
Check, check.
Lot of interest in using breast milk, especially the colostrum for oropharyngeal installation, and also something called colostrum painting. This is a practice that has gained widespread usage in many of the units because it's harmless and it encourages the culture of using breast milk in the unit. And there is some evidence, some limited evidence, which says that it is potentially beneficial, not directly in terms of preventing VAP, but this has shown to decrease the incidence of overall sepsis and some studies NEC also. And obviously, when you encourage the mother to start expressing breast milk so early, breast milk usage increases. So, colostrum swabbing and oropharyngeal instillation of breast milk is something that we can all practice. Closed suction systems, I'm sure you all know what these are. These are small apparatus that are introduced between the endotracheal tube and your ventilator circuit. You don't have to disconnect every time you have to do a suction. So again, there are not many studies, but they seem logical and they can be used especially in babies where disturbing the ventilation is going to be harmful. For example, a baby with very poor compliant lungs where you take out the ventilator pressure and de-recruitment happens, or PPHN babies where you don't want the ventilation to be disturbed often. But they are not known to prevent ventilator associated pneumonia as such. So it depends on the unit practice whether to use them or not. So I have tried to cover some useful things, hopefully are useful. So I would say whether it's for VAP bundle, whether it is for deterioration on ventilation, whether it is for how to ventilate, how to extubate, always follow a structured approach and understand the basics. Only when you know how something is happening, then you know how to troubleshoot it. So the best way to learn something is when there is a malfunctioning of the ventilator, you stand and understand what is actually happening. So when the biomedical engineer visits, you should interact with them and know what is a piston, what is an oscillator, and how the pressure is generated, what is a flow sensor, how does it work. So put a test lung and see how the graphics change. So these are not theoretical things at all. So the misconception that graphics, the way ventilator works, flow sensor, these are theoretical. It is not. Only when you understand these basics very well, then you can troubleshoot and you can do evidence-based care in the NICU. Thank you.
Try to take all the measures. Don't get satisfied like, okay, I have a TRA, okay, I have a TRA. Always try to get all the components what we have listed so that it will help us with using the PA. Also, baby is not responding. It is able to know why the baby is not responding. So how this functional echo has done, we have already